Yes.
Hello, can you hear me okay? Can you hear me? No?
आ रहा है ठीक है अब सबका चेक करा दे मेरा प्रोजेक्शन हो रहा है मेरे ये शेयर करके चेक कर ट्राई कर देने से बेटर He only did that. अच्छा ये प्रोजेक्ट उधर हो रहा है नहीं हो रहा है चेक कर देते हैं ये उधर प्रोजेक्ट हो रहा है नहीं चेक कर देते हो रहा है आ रहा है तो उधर आ जाएगा ऐसा सबका चेक कर ला ऑल प्रेजेंटेशन का कर दीजिए सबका लैपटॉप लेकर कर जीएसएल मेडिकल कर लो अब ऐसा हाईटेक बहुत जाता है not getting connected only stop share shall I close it or anyway
close it, sir.
डिस्टरबेंस होगा ना
लीव मीटिंग कर दिया मैं बाद में कनेक्ट
लिमिट
कैमरा
डिस्टरबेंस होगा ना
Hello, 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 hello,
Yeah, I can hear you.
hello,
Hello?
hello.
Can you move the camera closer or focus more? Because we really don't need to see the backs of the heads of people. Is that possible to move the camera closer or focus? Hello, is anybody listening? I guess that'll have to do. Hello. Hey, Dr. Teal. I can't hear you, Dr. Teal. Yeah. There you go. That's better. That's better. Better. Now just focus it in. That looks better. Better.
काढू लॅपटॉप हा लॅपटॉप काढू झूम कनेक्शनसाठी नाही ना लागणार
झूमसाठी आपण त्यांच्या ह्याच्यावर करायला
हे दोन काढू हे दोन बंद start.
Can you open the Wi-Fi setting?
Wi-Fi.
Hello, hello, check. Hello.
I think you need to turn the audio on of Gilbert and his laptop.
Good morning, everyone, and welcome to the KVV NeuroCon 2024, where the brightest minds in neuroscience have gathered to share, learn, and advance the frontiers of our field. We are all honored to have you all here, researchers, clinicians, educators, and students, each contributing to the collective knowledge that will drive the future of neuroscience. So, over the next 4 days, we will explore cutting-edge research, discuss emerging trends, and challenge our understanding of the spine and nervous system. So this conference brings together a diverse group of professionals, and is the diversity of thought and experience that make our discussions so rich and impactful. So now we will look forward to the innovative ideas and collaborations that will emerge from our sessions. So before we begin, I would like to extend our deepest gratitude to our sponsors, the organizing committee, and of all our speakers and participants for making this event possible. So now without further ado, let's kick off KVV NeuroCon 2024. For our first session, please let me invite our chairpersons, Dr. Ramdas sir, Dr. Dwakna Srinivas sir, and Dr. Sampan Chandra, and Dr. Aib Cherian.
I'll just say a word,
Okay.
guys.
France. A graduate of the Faculty of Medicine of Nantes, which is in France, he is a holder of diplomas in anatomy, neurology, and neurosurgery, with a fellowship in pediatric neurosurgery. Currently, he is interested in focusing on minimally invasive spine surgery, the training of neurosurgeons in the world, and in particularly in Africa, his continent of origin. As a holder of an MSc in health economics, he is equally concerned about the accessibility and equality to health. Let me please invite him.
Thank you very much. I'm very pleased to be here in India. It is the second time, the first time last year. And I remember in Nepal, when I met some colleagues from India, and they asked me, where are you from? And I say, I'm from France. They are not sure. And after I said, I'm from West Africa. Really? I'm sure you are coming from India. Yeah. So I feel myself at home in your country. Thank you very much, Hype, for this invitation. It's a family, as you say, to be with you. When you have an academic position, you have three missions. The first one, fundamental, is to treat patient surgery, neurosurgery for us. Second one is research, clinical research or fundamental research. And the third one, for us, for you, for me, at the same level, is to teach, to train the young neurosurgery. And this is my talk today, focusing on the low and middle income countries, 1.5, 1.7 billion people we need to teach, to share our experience, to reach the good ratio to treat the patient. Every year, an estimated 22 million patients suffer from neurosurgical disorders. And those people want the expertise of neurosurgeon. And we need 2,500 neurosurgeons to address more 5 million essential neurosurgical cases in low and middle income countries. This is those countries, mainly in Africa, my native continent. This is the estimated number of cases requiring neurosurgical operation by the WHO region. Look at brain tumor, spinal tumor, million and million cases we have to treat. The number of neurosurgeons in Africa is very low. Look at the ratio. It's around 1 for 1.5 million inhabitants. This is North Africa, it is another situation. Our goal is to train and to share equal and quality neurosurgical training across the globe without exclusion. It's not an Ethiopian because of the gap, money mainly, or political. And our ethics as MD impose a duty to treat each patient in the same way, regardless where he lives on the 5 continents. We have a lot of opportunities, mainly technological opportunities with digital resolution and the mobilization of our community as part of the global surgery. I am sure you have read this paper of the Lancet Commission. Who I am, neurosurgeon, of course, surgeon, and also a teacher. I wrote a book some years ago, Manual de Neurochirurgie, for the young neurosurgeon, for the students in France. It's a classical book. And with Professor Cassadi and Yoko, 10 years ago, I think, we have directed this book, Essential Practice of Neurosurgery. During around 15 years, I was the Secretary General of the Collège de Neurosurgery in France, responsible for teaching the specialty, the quality, the training, and accreditation. A good job we have had is the assessment of neurosurgeon skills by the French Ministry of Health. Important, each year, during 10 days, with the University of Montreal, with Bernard Charlin, we have courses on pedagogy, medical pedagogy. It is not because you are a good and excellent neurosurgeon that you have a good teacher. Pedagogy is a specialty. We have to learn a lot from these, our colleagues. And the last mission I had is Cassadi and some colleagues is the Campus Africain of Neurosurgery, Campus Africain de Neurochirurgie in French. The goal is to train 500 neurosurgeons in Africa. I wrote a paper, I make a review of the possibility of training around the world. You can read this paper on neurosurgery 3 years ago I wrote. As you know, the clinical setting, the wards, the OP theater remains where the student is in training. I don't want to insist, but clinical skills are required by the student, medical knowledge, analyze from the context of care, patient complaints, provide the best quality of care. The student must focus on combining an intensive clinical activity at the foot of the patient, bed, in operating room, laboratory, theoretical knowledge. What are the teaching methods? As you know, companionship is fundamental. And the student, the young neurosurgeon, must have a proximity of the mentor. It's a combination of face-to-face and e-learning leading to a final certification. Mentoring is fundamental also. Trainers have an active role in stimulating and incentivizing students' feedback for evaluations, monitor progress, and to ensure that deadlines are met. Have a self-assessment of the students. The tutor assumes the role of a resource person or organize an individual courses. And I say again, training the teacher. Prior education and training of the teacher is required. We have a methodology to better communication, knowledge, expertise, and experience. This is the connection we had with the Université de Montréal and a department of the University of Limoges in France, digital health education. I'm not, maybe you have one department of pedagogical education in your notes, you have to, dear Chancellor. For example, there's some techniques for video. You see a lot of video, but the videos must be brief, less than 20 minutes. Language, simple, direct, message is precise, striking, and attractive. Relevant content and quiz, image of the text must be focused on the gesture, a practice to learn by acting, and at the end, a conclusion, summary of essential points. And the contents of teaching must be peer-reviewed and evidence-based medicine, not a self-promotion, ego. You know that. We have digital resources for free, we have a lot, and we must have on the ground training mission, not only digital resources or theoretical resources. What are the modes of teaching? We know that lecture with PowerPoint presentation, but this is a vertical from the top for the student and the passive form. But it's interesting for adults, but the disadvantage of being exclusively theoretical and not very interactive. You know, those platforms are a lot of platforms, but this is passive. There is not really an interactivity, an activity between the teacher and the student. This is important to know. Maybe you know this pyramid knowledge, retention rates. There is a passive methods and cooperative learnings. People generally remember 10 are able deficit 10% of what they read, 20% of what they hear, 30% of what they see, and I go for 90% of what they do. So do and say, to practice by doing. This is very, very important to know, not only theoretical. It's an old paper written in 1946. There is another paper during the beginning of the 60s, very important, concerning this pyramid. I think that flipped classroom is one of the strategies to allow us to achieve our goal. It's not passive. Schoolwork at home and homework at school, flipped. It was created by Dr. Mazur from Harvard during the 70s. The group is supervised by the tutor expert. A topic is chosen and discussed in group. Lessons are freely accessible in digital format. The time in class is put to good use of practical exercises and interactive exchanges. This is very important to use the flipped classroom to share our experience. Difficulties are learning to surgical gesture. As we know, skill is acquired through repetition. Technical competency requires long-term learning, especially educating motor function in 3D space, where each millimeter is of vital and functional importance. We have to set up workshops. We have to set up laboratory directly in your department, in your ward, and we have to organize open training courses for microsurgery, neuroendoscopy, with anatomic power enhanced by scenarios. I have no experience with virtual reality, but I read that there is a paper on this topic. Maybe we can share and discuss on this possibility for neurosurgical training. And we do not, Kasadi, remember, we have only one book when we train. And currently, you have an application with your phone, and you can have app surgeon. It's very practical technique for sharing our knowledge in neurosurgery. Training missions, very important. The objective of this mission is to organize on-site workshops. This is an opportunity in small groups to discuss clinical cases, detailed technique sequence with analysis of delicate phases and risk. But it is critical to have access to modern and functional equipment. For example, in some countries in Africa, it's difficult to have a microscope, for example, because of the cost, the high price of neurosurgery equipment. And maybe we can have some solution from India. There is the basic set from the WFNS. It's a possibility to have a good equipment to work. And I have selected this slide because Professor Devendra Chabra wrote an obituary on this extraordinary man because of the price of the shunt. When I work in Africa, and the price of the shunt was $1,000, and people, the salary a month is $10. How can we pay? And Dr. Chabra produced a shunt only for $50 with the same result, with the shunt on the prices of $100. So we have to find equipment with low price but the same quality. There is for missions, there is for example, there is in Uganda a training program in a children's hospital that is CURE. A lot of students go in this hospital during some weeks for endoscopy, hydrocephalus. There is well organized, and maybe we can think to set up in some places in Africa a unity for a wall for the training of a young neurosurgeon. The problem is funding, but thanks to e-learning, expenses are reduced. Housing, travel, volunteering reduces the financial burden, and maybe the part of the profits obtained at the end of the grants, 1%, can be used to help our colleagues in Africa. Donations, sponsoring, and housing and meals should be taken care of locally. With some colleagues, we launched a Campus Africain de Neurochirurgie in French, because it is dedicated on the French-speaking countries, 20 countries. And we began in October, 3 years ago, and the course is once a month, every month. An evaluation of the course have done, and the teachers also, and the website have put online. And currently around 60 to 90 students participate each season. As I said, the objective is to train 500 neurosurgeons in a short time. There is a website with all the modules. We have around 40 or 50 lectures was online, and they are integrated in the modules, traumatology, tumor, vascular, etc., degenerative pediatrics, etc. It's running very, very, very well. I have contacted by Dr. Osman to create a link with SNI Digital Innovation Learning, because we have the goal to cover all the continent of Africa, including English-speaking countries, and maybe we'll find a solution to connect the Campus Africain Neurochirurgie with SNI Digital. Evaluation of the training is very, very important, and there is fairness. It is a tool. If you want to know if the goals have been achieved, you have to note that there is decreased perioperative morbidity and complication, measurable improvement in patient quality of life, education, ethical consideration, including decision-making, appropriate prevention, surgeons are staying in the country after training, fewer patients are going abroad for surgical care, junior surgeons are involved in teaching and training, and the country has a surgical and professional regularity society. and the center is recognized regionally and internationally. And we observe that in Africa for several years, and this goal is going to be achieved. Of course, there are obstacles, individual and systemic, heavy workload, loss of income, family obligation, young career, responsibility, skepticism, lack of support from colleagues, ethical concern, and security, and systemic obstacles, mainly weak political and financial support. This is a checklist we have. I will send you hyping, and I don't want to, the third point, the 13 points is too much to read, but you have to, I will send you. Conclusion, a high quality of neurosurgical training can be shared across the globe through the interactive, the active involvement of our neurosurgical community. It must be based on partnerships around a pedagogical contract. Pedagogical training of the trainers is fundamental, and the learning must be interactive and programmed over time. Local surgical, medical, logistical, and IT infrastructures must be available with excellent technical reliability. Thank you for your attention.
Thank you, Doctor. So now I invite Dr. Kazari Kalangu, who is a full-time professor and director of neurosurgery training program in Zimbabwe. He is also the honorary president of CANS, former president of ANSA, former second vice president of WFNS, and member of the Belgian Royal Academy of Medicine. So I invite him to talk on supraorbital approach to anterior fossa pathologies.
What a fantastic talk, Gilbert. So it really highlights how, as teachers, we are just part of the progress and the buck doesn't stop with us. We all, after we come to a certain level, it's quite common to assume that the buck stops here. But we are all part of the process. And the process is only complete when we pass on what we got much earlier than what we got to the people, the next line of people. So I see a lot of legends here, a lot of fantastic teachers here. And this is, I'm sure, this is what we do. And this is what we enjoy. So thank you very much for that talk. I would ask people to comment.
Yeah, it's a very thought-provoking talk on innovations. But a question to the general audience. I mean, we see as we go ahead that almost all the innovations are quite expensive. And the more advanced the technology, the more expensive it seems to become. But there are hardly any innovations, I think, like the Chavda shunt, which is actually very affordable. So why do you think this happens, and how do you break this cycle? Because every innovation seems to be adding on cost to the patient care rather than decreasing it.
Before you say anything, Gilbert, it was my great pleasure to hear you. I know Gilbert for a long, long time, and I've seen how he has progressed and how he has dedicated his life actually to serving lower strata of people and taking the level of neurosurgery to the topmost level of neurosurgery, and how he has struggled, how he is educated, and how he has reformed, and how he commands respect in the neurosurgical community throughout the world. Thank you for coming, Gilbert, and I'm sure the message will go deep. This is one of the examples as to how IPE is doing in this part of the world. The similar kind of project that you are doing for the world, he's doing for this part of the country. This is not such a big town, as you know. This is a smallish little town. and to bring all the kinds of equipment that he has brought, all the latest Kinovo microscope, you talk of exoscope, you talk of, you know, the things which I have not even heard he has got here in this town is not easy. I think what you could do is, you could sit down with Gilbert and give him some of your tricks and trades as to how to get neurosurgery, the topmost neurosurgery in a, I will not say remote town, but a smallish little town of Karad. What do you think, Dwarka? You agree? It's not a joke. It's not an easy job to make a center. Like this guy is different. This, my dear Ipe, is different.
In fact, I won't extend much, but I would add a comment because I have a personal interest in this. I spent 5 years in Uzbekistan trying to do what Gilbert did. So, in fact, I learned. I went there to teach, but I learned. What we forget sitting in these halls, in these big conferences is knowledge is okay, but transferring knowledge to a situation is an altogether different challenge. I'm sure most of us, if we are taken out of our OT system and asked to operate in, say, Keith's hospital, I'm sure we'll fail miserably. So who's going to teach this? As Professor Goel said, we have to take this, this capacity to do high quality neurosurgery to the neurosurgeon out there. So I think conferences should address this aspect. And I'm sure when we go, even for a short time, we learn to teach them how to learn the advanced surgery in a low infrastructure area. Thank you.
Just a small remembrance, back about 20 years ago, Professor B. Ramamurthy, he made one statement, India, we have reached one level, we step up. Now, all of you know that where we are now in neurosurgery. We stepped up in a rocket form, decided to transform, because initially we also had the 25 years ago, few institutions will have microscopes, but today India is different. In a small place, place where, I can't say small place, in my hospital we have 4 CT scans, 3 MRIs, and 2 PET scans in one unit. And India is too big. So this step ladder pattern, like he said about the transforming from the base to the next. So we have come to the next level. Probably I think we should give a big hand in developing the other countries now.
Thank you. One of the things in common between Professor Gilbert's talk and what Ipe has pulled off here is collaborations. I think it's very important that all of us collaborate. We all come to a certain level, we are on a platform and we have our practices and our teaching activities, but it's very important for events like this to bring together people, and I commend Professor Gilbert for the commendable work you've done, and Ipe for all the people that he has brought in here, and for his marvelous efforts in pulling off an excellent center of excellence here in Karad, and for organizing this wonderful show. Thank you.
Your presentation is very informative. I have 2 comments. Any international effort to improve neurosurgery in low and middle income countries should take input from young people, residents and young faculty from these countries, because they're the stakeholders. Eventually they'll get affected. The second comment, it's not one way. Developed countries teaching developing countries. See, we are very good in managing very high volumes. Okay, in NEMANS and many other institutions, we see almost 200 neurosurgical cases per day. And also, we learn how to deliver good quality of work with very less expenses. So West can learn from us. Industrialized countries can learn from us. You can put these ideas into the decision-making bodies, WFNS or anything else. Thank you.
Thank you very much. And I'm so glad to be here to meet my friend, my old friend now. He's no longer a friend, he's a brother. Hyperion. Okay. We know each other since more than 15 years. When he was going around to try to convince people that his technique worked, and there were a lot of resistance. So until we had a discussion, and I had the impression it was just so clear for me, and offered him to write a chapter into the book which Professor de Champenois just showed. From that time, now the technique was sort of accepted, but there's still some fight to be done, but it doesn't matter. That's life. Okay. And thank you very much also for all organizers. For me, it is a dream to be together here. It's more a family gathering, as you said, and you see how science can make the world so small. 2 days ago, I was 10,000 kilometers from here, and now I'm here with all friends, brothers, and everyone. This is magic. So I'm going to talk to you about the supraorbital approach to, in fact, when we started this technique, it was for pituitary tumors. Then we extended it for other pathologies as well. What you are trying to show is how it is simple and it can be done anywhere as soon as you have just few items to use, instruments. Okay. Historically, this is not a new technique. It was already described in 1900 and by Krauss. Okay, he demonstrated how to get to do supraorbital, subfrontal approach on cadavers, and he did his first resection of skull-based meningioma through this approach. That's in 90s, in the 1930s. Frazier advocated also supraorbital, resection, and he said it was very good, for the operation of pituitary tumors. And in 1990, Pernesky and colleagues popularized this keyhole concept. And actually, the evolution, however, began with Fedor Krauss. More recently, Jane and Delachaux described the supraorbital craniotomy and this approach to orbital tumors. There are also plenty of variants, for example, described by Professor Al-Mefti. As usual, we are scientists, we doctors, but at the same time, we are also artists. So you can have a lot of variations. The important thing is to choose the simple one, the best one, and the one you can afford, which can give the best results. That's the important thing. You keep it simple. Now, this is the way we started this kind of operation. Until 1994, as Professor Champenois said, we had few data published about pituitary tumors. And in fact, some people were saying they do not exist, those tumors. Okay. And why? Because the CT scan was not popular or popularized, and also people didn't know how to make a diagnosis of this pathology. There was lack of technology and lack of instruments as well. Yet, 21% of brain tumors were pituitary tumors. So, and you see this is the demography. I don't want to go into details. It's not different, actually, just to show you that it's not different from what we see elsewhere in the world. Okay, and 83% of patients were blacks. The reason why I'm saying blacks is because Zimbabwe is a mixed community population. So, of course, since 83% were blacks, you see more pathology in black people to confirm that this pathology exists also in black people. Now, this is also very interesting. The first doctors to refer patients were actually general practitioners. Which practitioners? Which actually students in medicine, I taught. And then those are the ones who were sending me patients. Then ophthalmologists, of course, because patients were having problems of visual field or visual and so on and so forth. Gynecologists, they were very resistant. They didn't want to talk about it because they knew how to do it. General symptoms, the usual one, there is nothing new. But what is specific a bit, what is very interesting in Zimbabwe at least, and in Africa in general, when there is a decrease of libido, people, they deny it. They think, oh, it's something, which happened because there was somebody died or they was depressed and so on and so forth. Nobody's talking about it. The galactorrhea, well, it's milk. So that's not a problem, They go to the gynecologist, Secondary amenorrhea, that's more a problem because usually people are having also difficulties to have babies. Depression, of course, they will send them to some other colleagues whom we all know. This is the average. The study was done on 4 years. Clinical findings, mostly visual impairment in 85% of people. Decreased visual acuity in 25%, blindness in 8%, and alteration of visual field in 32%, which you can guess it means they are big tumors, huge tumors. And the commonest tests, we couldn't afford a lot of tests, and those are the only clinical tests you could do into these patients. And I presented this actually talk to specialists and they were very impressed, and they said, how could you treat patients? They said, with just those few investigations, you can do a lot. And of course, clinical examination. This is the type of tumors which were there and so on. Now, interestingly, we could see all those tumors because we had now access to CT scan and also MRI. You see that the MRI numbers of patients who actually had MRI is actually superior to those who had CT scan. It's just that some patients had CT scan and MRI, which is very good. This permitted, of course, to make a diagnosis and operate those patients. And before, we were using the transsphenoidal approach to remove those tumors. Fortunately, we didn't have any death, and patients were improved in terms of symptoms, 83%. And of course, blind patients never recovered. We had a bit of morbidity like diabetes insipidus, which is expected, and change visual acuity, 2% of patients, CSF leak, and so on and so forth. Now, this is the most important part. Within 15 months, we saw that in patients who had microadenoma initially with supracellular extension, we saw a recurrent rate of 10%, okay, which is quite high, okay, which means that we didn't remove completely the tumors when we did transsphenoidal approach. And after 5 years, the recurrence rate was 18%. So this made us think whether our technique was not good or we didn't remove completely the tumors. So we had to look to alternatives. That is the important thing, to review the work you've done and then position yourself and correct the mistakes. And we had particularly the problem, particularly on stage 3 and stage 4 of patients having macroadenoma, which we all know, this particularly in this area here. What is the goal of anterior skull base surgery? Okay, ideally, it's a curative surgery. So we require to remove completely the tumor. That will be the ideal situation. But the most important thing is that we reduce brain and nerve retraction, which is very important as well. So we minimize stress to the optic chiasm and the frontal lobe. And of course, this will help to have visual improvement, okay? we can also preserve both, at least one olfactory nerve, okay, which is very, very important, okay. We prevent some complications you could have with the sphenoidal approach, which is CSF leak, for example, okay. But of course, you need to be versatile, whereby you can change your technique. You can modify while you're doing the operation according to the situation which you find, into your operation. And you see here different approaches which people have done in the world, according to the situation, according to the symptoms of the patient, according to the facilities neurosurgeons have. And this is typical approach. A lot of people have done that, craniotomy. And of course, I'm talking about this technique, okay? Very important to remember, okay? You have to localize the supraorbital nerve, okay? And you can stop the incision here. Usually I go beyond that without cutting the nerve, of course, on the subcutaneous area. And then when I cut the muscles, I make like a U like this, so that I can protect, the nerve. Now, there are always some criticism, and we saw a lot of report and papers. The primary one was that those minimally invasive approach is that there is limited field of view. But if you have a good microscope, it's so simple. Okay? I'll show you the images. And also, they were saying there is a possibility of partial removal of the lesions. But I found that with that approach, we could actually see much better the tumor. We could see actually the optic nerves. We could really do a proper work according to our experience. You see there are a lot of variants, This is basically the one we use most of the time, okay? Supraorbital craniotomy or eyebrow incision, okay? Now, there are a few things which are very important. First of all, is the positioning of the patient. You see that the head is in hyperextension. Look at the angle here. That's very, very important. Because the moment you start to drain the CSF, the brain will fall towards the calvarium and giving you a lot of room on the base of the skull. You don't even have actually to retract the brain. The brain actually moves back and you have plenty of space. You see this line, that's localizing the supraorbital nerve, which needs to be preserved. I used to do these big incisions, particularly when the tumor is extending towards the opposite side, so that you can actually approach lesions, even on the opposite side. But here, I can just stop here, and you have a lot of, you can see quite a lot of things. After all, that's what we do when we do aneurysms and other number of neurosurgical procedures, when you have a good microscope. This one, I should confess that I took this picture, with this plastic thing. I don't want it actually, because those things, they bring infections, because patient is sweating under this cover. But for the presentation, it looks nice, to do that, but I don't do it. So here we are. And initially, when you open the dura, you do the craniotomy. That's the view. You see it's quite dense, okay? You see here, when you drain the bit of CSF, okay? And the CSF is released. You see that you start to have a space here very easily. And you can actually see now, you can visualize the tumor. And you don't need a retract actually. That's the size of the bone flap, okay? It's very small, okay? It has to be small, that's true, but you need to have room as well. Look, here, we are not retracting at all, just holding the brain, not retracting the brain. And you see here, you have the right optic nerve. You see we have the tumor here, very easy. So it means you can remove the tumor. You can also observe the optic nerve. It's so simple. And you see there is quite a lot of room. For that, you have to open, of course, the systems, and you do the usual microsurgical resection. After the operation, ladies, they love, to have these scar on the eyebrow, and after when they put the black marks and so on and so forth, so you don't see anything. They are very happy to have that, So we did 35 patients, 12 meningiomas, 22 pituitary macroadenomas, okay? And guess what? The recurrence rate, the recurrence was now much lower. It was 1.3. You remember the recurrence rate I showed you earlier on. See this patient before the operation, after the operation. You see this patient here, before the operation, after the operation. These patients again, before the operation and after the operation. You see here, tuberculous mycelial meningioma, before the operation and after the operation. Okay. So it's so an easy technique which can be taught to students, first on cadavers, of course, and then progressively, step by step, they learn how to do this operation. In conclusion, this is a simple and affordable technique. It allows large space for microsurgery. If you're doing microsurgery, we have plenty of space. You can go actually as far next lateral side and left. If you're operating from the right side, you can actually see also lesions on the left side. There are many, of course, there are many surgical options. I'm not saying that's the only technique. It's good to have how in Africa we say when you go and hunt, always have more than one bullet, So consider tube extensions and the reconstructions is very important, okay? Sometimes frontolateral approach is preferable, okay? Now, you can actually combine with endoscope also, and it helps. If you have an endoscope, you can combine and do with the surgery in some pathologies. But the most important thing is that you can see the optic nerve. It allows visual function preservation, if of course the visual function is still present. And also what is also interesting is that in this approach, you have an early optic canal and roofing in case of invasion. That's the superiority, really, absolute superiority of this technique. Thank you very much for listening to me.
Thank you, sir. It was a very nicely done talk. I wanted to ask you a question. Do you combine your supraorbital craniotomy with an orbitotomy to increase the angle of approach? Because there are a few authors who have described that through the same suprabro incision, apart from doing a small craniotomy, you could do a small lateral orbitotomy. And since the orbit is what you call the eyeball can be pushed down, and you get a bigger angle of approach to the skull base.
Yeah. No, I don't do that. What I do, in fact, if I suspect that I will have to go laterally, so I just change the position slightly. I move it by 15 degrees, for example, to the left side, or depending. Usually I approach it on the right side. So I just move a little bit, 15 degrees on the left side, and you solve the problem.
Any other questions?
Sorry, come back again. Okay, yes, yeah. We haven't done yet aneurysms on that approach, okay, but it is possible because you can see very, very well the vessels and so on. And the most important thing is to be able to control the bleeding if you have a bleed.
what do you think about orbitozygomatic osteotomy and all those things? Do you still do them or you don't do?
Yeah, for huge tumors, you know, with lateral extension and things like that. Of course, I mean, you have to adapt. There is still room for that. Absolutely, yeah. This is not the only technique. This is the only technique in a certain number of tumors, okay? But you can use that technique as well, absolutely.
Please.
Thank you very much, Professor, for the talk. I wanted to find out if at all you combine with the transphenoidal approach or you just use it in unison.
Okay. The only time we've used transphenoidal approach as well is when the tumor has extended below the floor of the sella turcica. Okay. That's the only time we use the combination. Otherwise, from the top, you can actually remove completely all the tumor. You have just to be patient and remove it progressively. Yeah.
Thank you. Thank you, Professor Kalangu. That's a wonderful talk. And now it's a great pleasure to invite our teacher. Sir is going to speak on my contribution to skull-base surgery, which I think everybody knows. So, but still, he has so many contributions, it's difficult to enumerate them. So, over to Professor Atul Goyal, sir.
Topic has been not selected by me, has been selected by IPE. What do you think about computer and all? How do I run my slides? Good morning, dear friends. I'm going to summarize my lifetime work in next 20 minutes, and I hope you try to get what I want to say. I can only say that I have spent a lifetime in neurosurgery. I have to only say that I was the most fortunate to get the most wonderful opportunities in neurosurgery. I worked in mother institutions where I was just operating all my life. Most important in neurosurgery is to operate, to do neurosurgery. That is most important. And most important in neurosurgery is to keep on operating. And that opportunity I got in my hospital. I became a neurosurgeon when I was 26 years old. And I became head of department of KEM Hospital when I was 36 years old. And from then on, it has been a journey. It has been a dream run for me. And I think if somebody asks me if you can repeat it, I don't think I can repeat what I have done in my career during this lifetime of neurosurgery. I have done what I have done. I have got what I have got. And I have enjoyed my journey. So some of the things which I have done in brain surgery, I will like to enumerate. So this is my book of neurosurgery. These are the two books which I have written in my. This is the cranial neurosurgery, essentially cranial and skull base. And this is book I wrote on craniovertebral junction and spine. So today I will talk on cranial skull base neurosurgery. This book I wrote in 1996 with Professor Kobayashi. And if you see in 1996, you see the cover page of the book where I am mobilizing the carotid artery, Gasserian ganglion. You see the facial nerve has been mobilized. The entire pectus bone has been drilled. You can imagine One thing is to do such an operation. Second thing is to have an access, all the kinds of technology, all the kinds of things that you need to do such an operation. And then to make a line drawing like this. So you see, I had a possibility of making line drawings. And that is which took me to several publications during those years. Most important is not the person. Most important is the surrounding and opportunities. And to young people, if they want to have one message from me is get opportunities, look for opportunities and extract and use those opportunities. That is the most important thing in life. And for me, KEM Hospital, when I joined, KEM Hospital was very famous hospital with stalwarts of neurosurgery, stalwarts of anatomy, stalwarts of orthopedics, and they were working with me in close quarters. And one of the most important persons of my life was Dr. Manu Kothari, who introduced philosophy in my life, philosophy. And those who have heard me, those who have seen me through the years, they know of my philosophical articles. And there are several. Cavernous sinus philosophy, how the role of eyes, role of cavernous sinus, role in vision. Cavernous sinus, its role, nobody has ever written about cavernous sinus and its role in vision. Role in eye movements, nobody has ever talked about whether cavernous sinus itself is having some role in eye movements. We talk of cavernous sinus as a venous complex. We talk of superior sagittal sinus as a venous drainer. Nobody has talked about cavernous sinus, and there are several articles of mine where we have talked about role of cavernous sinus in controlling temperature, controlling pituitary gland, controlling the function. You see, this is cavernous sinus, its relationship with the sphenoid sinus. This is pituitary gland. It is neither intracranial nor extracranial, relationship with cavernous sinus, relationship with nasopharynx and sphenoid sinus, and things like this. How the temperature regulation occurs in nasopharynx. When we drink or eat anything hot or cold, as soon as it goes beyond the mouth in the esophagus, the temperature is normal. The mucosa, which is the most vascular structure in the body, nasal mucosa, if you go in extreme cold or extreme hot, as soon as that air goes beyond the nose in trachea, it is normal temperature. How the terminates churn the air, how the in middle terminate, lateral terminate, this, how it goes from here to there is a beautiful, nobody has ever talked about it. And you can read in some of my beautiful philosophical articles. A technical neurosurgeon, a surgeon who is involved in surgery, talking about philosophy is not very frequently seen in the world of neurosurgery. So these are some beautiful articles that you would like to read. In 1996, you see at that time, petrosal approach was born. By Hakuba was the main star of petrosal approach. He described those approaches in early 1990s. Combining middle fossa approach and combining posterior fossa approach was not very common 30 years ago. So this was one beautiful article of mine, which I am very proud of, which combined regular subtemporal craniotomy with mastoidectomy. So mastoidectomy and subtemporal, this was the first time it was used, and if you see this approach, how it was cutting of the root of zygoma, roof of condyle, roof of external canal, partial mastoidectomy. So skull-based surgery was being evolved at that time, and some of these beautiful articles contributed certainly to the growth of the subject. And this is extradural approach to the region of petrous apex after doing such a basal work. Then I started minimizing my approach, and if you see this beautiful, and concentrate on the line drawings. How many people in India, how many neurosurgeons can have access to line drawings, which I had beautiful access. And you see these line drawings, temporalis muscle rotated anteriorly, this kind of incision, this kind of mastoidectomy was a norm in my operation theater. Then we started splitting the temporalis muscle, splitting. splitting and minimizing the approach. So in 1997, 1998, during that time, my exposures has already started becoming reduced. I used this extended lateral basal approach for petroclival meningiomas, for trigeminal neurinomas early in my career. Then, of course, I reduced my exposures. And this, my young fellow from Yemen has come, and he remembers this statement of mine. Alum al-Dimag is from Quran, this statement. And it means the meninges are mother of brain. I used this sentence in 1992. And believe me or not, in this gathering like this, Al-Mufti was sitting. Sam Al-Mufti, as you know. And after my lecture, he just hugged me like this. He says, beautiful sentence and all those things, and how you got this sentence. And he took my interview for quite some time. So meninges are mother of brain. Dura is like a sheet. There is no hole in the dura. As the arteries go out or in or nerves go out, the dura goes along with this. And this dura anatomy, dural configuration has been a subject of at least 50 articles of mine. And I think they contributed to an extent. So as I mentioned, I was born a little early in neurosurgery in my life, and I got access to all kinds of complex neurosurgery very early in my career. So 1992, 93, I was doing cavernous sinus surgery on a regular basis. And some of these articles which I wrote on cavernous sinus were not very common during those years, 30 years ago. And meningeal architecture of cavernous sinus surgery, and how the cavernous sinus can be exposed, the triangles of cavernous sinus, they were of course there, but not to that extent. And extradural approach, we have heard Vinko Dolenz talking about extradural approach to aneurysms and things like that. So this was the first time in the literature where extradural approach to tumors was described, tumors. Cavernous hemangioma of cavernous sinus is one of the most difficult neurosurgical problems. In 1991, this article was, I'm not sure it is there or not, 1991 this case was published. This was the first case in the literature where preoperative and postoperative images of cavernous hemangioma were shown. We described extradural approach to cavernous hemangiomas of intracavernous, most vascular tumor, most benign tumor of the brain, and the most difficult neurosurgical problem, extradural approach. And this approach is very frequently and commonly performed, and there is no other approach other than you cannot come for cavernous hemangioma from the nose, and if you have not known this tumor and you attack this tumor from the nose, you have actually demolished the patient. You will have such furious bleeding that you will not be able to control. So these are vascular tumor. You have to understand an extradural approach, in my estimation, that we describe is one of the most phenomenal and one of the most accepted approaches for these tumors. No matter how big this tumor becomes, it respects the mother dura, and it goes towards the Meckel's cave, towards the orbit, towards the intercavernous sinus. Dura is respected. It is a slow-growing tumor. It is an extradural approach is the most phenomenal, most beautiful approach for these tumors. Trigeminal neurinomas. Many of you who are doing trigeminal neurinomas know about these contributions. This article of mine, published in 2003, is the most highly cited article on trigeminal neurinomas. This article I am very proud of because there are several beautiful things in this article. One thing we said for the first time in the literature was that trigeminal neurinomas arise in the region of Gasserian ganglion. Second most beautiful thing we talked about was interdural approach. These tumors remain within the dura of the middle fossa here. Believe me, in 30 years ago, 35 years ago, nobody knew what trigeminal neurinomas are. Nobody knew how to operate on these tumors. So we said that these tumors are within the dura. In 2003, we said that these tumors here in the posterior fossa component are like acoustic tumors. So this we later changed, that many of these intracranial tumors are also interdural. This middle fossa cavernous sinus area tumor is certainly interdural, no matter how big it becomes. Believe me or not, this concept has completely revolutionized trigeminal neurinoma surgery. And now if you see any skull base or any regular neurosurgeon, if he gets a trigeminal neurinoma, he gets excited. 30 years ago, if he gets a trigeminal neurinoma, he used to get depressed because he didn't know how the hell to enter into that area. Now you see the beauty. This approach we described in 1995. Approaching this kind of tumor in 1995, 30 years ago, was not easy. To identify that this tumor is trigeminal neurinoma on the basis of clinical observations like numbness of face, wasting of temporalis muscle, to identify this is trigeminal neurinoma. That was one beautiful thing. Second thing is to identify that this tumor will remain within the dura. And the third thing to identify is that you can approach this tumor by just widening the Meckel's cave. Widen the Meckel's cave, work within the dura, and remove the tumor. Other thing I forgot to tell you about my previous article, which is highly cited. First time in the literature we said that you can improve the trigeminal function in trigeminal. Nobody had ever said. Imagine removing this tumor without a craniotomy. Was never discussed. Removing skull-based tumor without a craniotomy was like a dream come true. And we did not only for such tumors, even this was from that article in 1995. Tumor going in the posterior fossa. You see, if you have read articles from Cushing, and if you have read article from Al-Mefti, much later, Al-Mefti said tumors, and this article of Al-Mefti was published as a cover page of Journal of Neurosurgery, where he said that this kind of dumbbell tumors were the last chapters of neurosurgery. Unfortunately, he didn't even refer my article, which was published much before, where we had removed such a tumor without a craniotomy. So we also then discussed that trigeminal neurinomas which go extracranial are within the dura. Very great clinical implications. We said that tumor in the middle infratemporal fossa within the dura. So this is V1 division, V2 division, V3 division within the dura, and you can remove this tumor by transcranial route. Even when the tumor recurs, it has a dural configuration. It is within the dura. Very huge surgical implications. Another beautiful thing is to identify oculomotor neurinoma from clinical symptoms, and then to realize that this oculomotor neurinoma is within the dura. You know, earlier and still many people think that the dura is the capsule of the tumor. If you have that concept, you have completely demolished the third nerve. You have to open the dura, work within the dura. This dura is not the capsule, it is the dura. And if you just debulk the tumor, avoid the dura, you can save the third cranial nerve and improve the third cranial nerve function, which was never described in the literature earlier. Similarly, this skull-based tumor, one of the most dramatic and dangerous skull-based tumor, but on the basis of clinical observation, like this patient comes with dense facial nerve weakness, you realize that this is facial nerve neurinoma. If you realize it is facial nerve neurinoma, that you have to realize that it is within the dura. If you realize that it is in the dura, if you realize it is soft and suckable, you open the dura, save the fibers of the seventh nerve, and you can actually save and preserve and improve the function of seventh nerve, which is very rare, of course, but this interdural strategy of seventh nerve neurinoma is quite, and you can approach this tumor in half an hour. Soft tumor, cystic tumor, necrotic tumor, don't remove the capsule, that is dura. So that is, I think, quite a beautiful, similar concept for lower cranial nerve, interdural approach. Believe me or not, great. And this is the first article in the literature, if you read, where we have said you preserve the dura. That is one thing. Second thing is, we said that you can improve the function of the lower cranial nerve. For the first time in the literature, we improve. If you read this sentence is not here, but this is a possibility to improve lower cranial nerve function. So this kind of tumor, multi-compartmental, have a big wide exposure of the mastoid, of the extracranial, of the intracranial, then little bit open the dura. Learn the art of demolishing the tumor by preserving the dura. Like for intracranial meningioma, art is break the tumor, then preserve the arachnoid, dissect the arachnoidal plane. These kind of skull-based tumor, break the tumor, preserve the dura. And that is the trick to remove. Even the extracranial part is within the dural confines. So I thought that that is a beautiful article. Another beautiful thing, C2 neurinomas. If you see 2008, we reported 60 cases, and this was my concept, that this part of the tumor is intradural. This part of the tumor is interdural. So here you work within the dural confines, here you work in the subarachnoid space, like trigeminal we said. In 2018, you see the drawing has changed. This has also become within the dura. And for the first time in the literature, we remove this tumor. This is C2 neurinoma. This is outside the canal. C2 ganglion is different. It is not in the foramen like all other ganglions. All other ganglions are in the foramen. This is outside. C2 ganglion is outside the spinal canal. Understanding that it is C2 ganglion tumor, understanding that it is within the dura, you can remove this tumor without a laminectomy. So we remove these tumors without laminectomy for the first time, without any bone work. Chordomas. Chordomas are very favorite skull-based tumors. And this article of mine, I love this beautiful article in 1995, where we said that chordomas are soft tumors, chordomas are bone tumors. They involve and destroy the bone and displace the soft tissues like cavernous sinus, carotid artery, sixth nerve. The sixth nerve is, partitioned from the carotid artery. Carotid artery is here, the sixth nerve is here along the cavernous sinus. So this distance, this is first time we said in 1995. And accordingly in 1995, we designed this middle fossa approach. Carotid is anterior, you come from lateral, cavernous nerves are here, dura is here, and you attack the tumor from this area. So although nasal approaches and endoscopic approaches are relevant, but there is a big spot for transcranial route. More recently, we talked about supracerebellar approach to clival chordomas. This is the tumor. You can come from the nose, you can come from middle fossa, but if you remember, the sixth nerve is going to be here. Carotid is going to be here. So all this distance. So what we do is supracerebellar, identify the sixth nerve early in the operation, protect the sixth nerve and save the sixth nerve. These tumors are jelly-like, attack the tumor, and you can do a radical resection by this approach. Early in my career in 1995, as you have seen, we were doing a lot of facial nerve mobilization, carotid artery mobilization, and petrous bone drilling. Of course, I don't do too often nowadays, but this was my approach, and Ohata had, published, and of course, some people recognize, most people do not recognize my articles. You will be surprised that I have written more than 100 letters to editor because this fellow has not acknowledged my article and this article, more than 100. So to publish from India is not easy, to do from India is not easy, and to be recognized from India is not easy. You must know this. So there are some who recognize here. More recently, in 2004, we described supracerebellar approach. Now, this supracerebellar approach has become very popular in the world. And I have written 5 letters to editor since my publication because this was not acknowledged. So that is another part of the story, but supracerebellar approach for petroclival meningioma, I have now done several of these cases. You can have a quick exposure, you can have a dramatic exposure, you can do beautiful things with this approach. Midline foramen magnum tumors, at that time when I was in skull-based neurosurgery, I was working with Laligam Shaker, and he had described extreme lateral approach, and extreme lateral approach was very common approach practice for skull-based neurosurgery. There were workshops being held all over the world for extreme lateral approach. So during that time, we described midline approach for many of these anteriorly based foramen magnum tumors. Now I do not ever do extreme lateral or far lateral. This is a beautiful approach. You can have carotid artery control, you can work within the nerves, and you can do beautiful operation. Pituitary tumor, another subject of my great interest, and I have done, the other thing beautiful is my number of my cases. I have done more than 5,000 pituitary tumors in my life. I think not many people in the world could get those numbers, and many articles on the subject. And most beautiful thing we said that the dura, this dura of the diaphragm celli is elevated by the tumor. And this, in my view, and there is no controversy in my mind, this concept that the dura of diaphragm celli is elevated by the tumor has revolutionized pituitary tumor surgery without any hesitation. This kind of image that you are seeing, if you do not have the concept that the dura is going to cover this tumor, you cannot remove this tumor. This elevation of the roof of cavernous sinus dura, elevation of diaphragm dura, this is also a huge concept in pituitary tumor surgery, which we first described 30 years ago, and it is game changer in the field of pituitary tumor surgery. How the tumor involves the cavernous sinus, how the lateral wall is involved, how the roof is elevated, how the dura is elevated, are beautiful new chapters in pituitary tumor surgery. So this was my classification, that the diaphragm can go up till corpus callosum or beyond. It is thinned out, and if you have this concept, you can remove this tumor from the nose, and in quick time, and in a beautiful, learn the art of breaking the tumor, learn the art of respecting mother dura, and you can remove this tumor in quick time. Learn the art of respecting lateral wall, learn the art that lateral wall contains nerve. Learn the anatomy of this area, how the carotid is displaced, how the sixth is displaced. You can enter into cavernous sinus. Not easy. Learn that the dura is elevated, roof is elevated. The third nerve is going to be separate, and there is going to be a dural layer here. This concept can completely change your surgery for pituitary tumors. Not easy, but possible and best. Some tumors go beyond the diaphragm, and that can be a dangerous situation. And this concept of diaphragm, this concept of dura, in my view, is completely different concept of pituitary tumor surgery. And there are several articles in the literature talking about pituitary tumors and about cyst levels in pituitary tumors. Another subject of mine, which I'm interested in, is, one is chordoma, soft tumors. One is epidermoid tumors, soft tumors. One is craniopharyngioma. Craniopharyngioma and chordomas are brothers. Both are benign in nature histologically. Nobody knows when chordoma will recur. Nobody knows when craniopharyngioma will recur. Epidermoid, of course, is a soft tumor but benign tumor. And I have recently talked about, I don't have slides of craniopharyngioma, my papers on that, but beautiful how to remove craniopharyngioma, how to protect the pituitary stalk. This epidermoid tumor, largest series in the world reported. In one meeting we held in Mumbai about 20 years ago, I said epidermoids can occupy any place in the brain. They are like slums. If there is space in Mumbai, anywhere, slums will grow. So epidermoid tumor can grow anywhere there is space. So, but the most beautiful space that epidermoids find is around the tentorium. And they go up in the incisura, above the tentorium, below the tentorium. So this approach, supracerebellar transtentorial approach, is the most beautiful approach for these tumors. They are tentorial based epidermoid. They are not in CP angle. The CP angle terminology is not correct. So epidermoid's pineal region is posterior tentorial incisura. You get epidermoid tumors. This is also largest series in the world. Endodermal cyst is an enigma. Nobody used to talk about endodermal cyst in the world. There are recent papers and recent articles, and we said about endodermal cyst, these are like purulent material, dangerous location, but most easy tumors to remove, but most philosophical tumors to remove. How to preserve the capsule, whether you need to remove it completely or not. In this article, some beautiful things are mentioned, and I wish you can read it. Colloid cyst, this is also one of the highest cited article in colloid cyst. I wrote this article in 2002, and then subsequently there are many more articles. Tuberculum celli-meningioma, this is also, you will be surprised to hear this repeatedly. Tuberculum celli-meningioma, olfactory groove meningioma, both are highest number of cases in the literature at that particular point of time. Antioclinoidal meningioma, difficult, dangerous tumors. Meningioma, some philosophical, beautiful articles that you will like to read, and I wish that you read on cavernous sinus meningioma. Meningiomas, are they curable? Is total tumor resection necessary in acoustic tumor surgery? Can you handle this kind of facial weakness even if it is mild, or you would like to have this kind of smile? My now current concept in acoustic neurinoma surgery is that you should not tease the facial nerve from the tumor capsule in large tumors. If you tease the facial nerve, you can destroy the face. There is a big danger of destruction. So what in large tumors nowadays I do? In large tumors, small tumors of course are different. I do not even attempt to remove the capsule of the tumor along the facial nerve, because face is so important. Because you cannot cure acoustic tumors, because you cannot cure meningiomas. Curing is a non-issue in meningioma. Another beautiful sentence which many people do not like is, recurrence of a meningioma is independent of extent of tumor resection. We talk of Simpson grading, grade 1, grade 0 and all those things. I have written on some occasions that whether you resected 110% or you resected 90%, it does not make much difference. Of course, if you resect 1%, it will create some kind of an issue. Nasopharyngeal angiofibromas, mother dura is present, mother bone is also present. So these tumors, I described transcranial approach for the first time, but now I think transcranial approach is not a good option for this. Another beautiful approach, imagine, just many of you are young people, imagine 35 years ago, removing a right side tumor from the left side. Don't you think it was innovative, ultimate? You agree or you don't? 35 years, not today, to remove a right parietal tumor from the left side. I think this was one of my greatest innovations. But now you see, my trouble is many people try to talk about transfalcine approach and all, but the reference, you see this even Lawton, this is another approach of mine, transfalcine resection of AVM. You first come here, attack the anterior cerebral artery, and then you come from here and remove the, the draining vein to the superior sagittal sinus. So transfalcine approach, another beautiful approach. We removed completely and entirely middle fossa approach from the posterior fossa. Supracerebellar transtentorial approach to middle fossa tumor. So this was the first time a middle fossa tumor was resected from a posterior fossa. This is also, I think, contributory to the literature. Then, of course, we worked on white fibers, and we have beautiful approach. I don't know whether Malla knows about my middle temporal gyrus approach to amygdala hippocampectomy. We first described 30 years ago. And one of my friends wrote a thesis, one of my students wrote a thesis on that subject. And then multiple articles on white fibers, and then our recent work on gliomas is confined, and you can remove this tumor en masse. Confined tumors, they grow along the white fibers. They grow by expansion. They affect the adjoining tracts by virtue of pressure, not by virtue of destruction. And so this is a huge concept in glioma surgery. And you can have a well-defined plane of dissection around the glioma, and you can remove gliomas en masse. So this is a different version of glioma surgery, and I have no doubt, no hesitation to say that it is quite a beautiful and possibly a futuristic kind of technique for gliomas. And we described orbital cortical approach and all those things, arteriovenous malformations, We have got one of the largest series in the world, one of the most phenomenal kind of cases we have done and presented on several occasions. And many of you have been following my career, know how many times I have presented on AVM surgery. Pile AV fistula is also one beautiful chapter of vascular surgery. Skull-base reconstruction is very important, and I have got at least 10 or 12 flaps, vascularized flaps, extended vascular osteomyoplastic flap, subgaleal pericranial flap, multiple flap, and these kind of flaps you will like to read, and those who are in skull-base surgery will like to probably use them. Use of nasal sphenoid mucosa, small and simple technique, but it is a good technique to use nasal reconstruction. Then we talked about infections and about aspergillomas. Our paper on aspergilloma is the highest cited article on aspergillomas. Then we talked about various philosophical things about shunts and all those things. And if you ask me, beautiful. This is most under-recognized thought in neurosurgery. With the preoperative shunts in posterior fossa tumor surgery, for the first time in the literature we said that hydrocephalus is a natural protective phenomena. Doing shunt is a negative thought. On supracellular tumor, on thalamic tumors and various, these papers have been under-cited and under-followed. But in my estimation, one of the most beautiful chapters of neurosurgery, which eventually people will give a more important thought to this. These are some kind of, another beautiful thing, third ventricular aqueductoplasty. We describe putting a tube in the aqueduct for the first time in the literature. And then subsequently, many people have done aqueductoplasty. Very few have actually cited this contribution. And these are some beautiful things. This orbital advancement is another, this kind of technique we use for orbital advancement. I reported, I don't do much of this craniofacial work nowadays, but during those days I used to do many of these kind of cases. And philosophical, last but not the least, the best part of my whole career is some beautiful philosophical articles which you must, and I wish that you read some of these articles. And this was a very simple technique of closure. So I thank you all for listening to my journey of neurosurgery. And my wife is sitting here. She is the participant in my life of neurosurgery. Neurosurgery is not just a profession, it is life. You have to love neurosurgery, you have to live neurosurgery, you have to enjoy neurosurgery, and you have to grow into the subject by being in the subject, by operating and by continuously operating. So thank you very much.
Thank you, sir. As usual, it's a pleasure listening to you and reliving this journey of Indian skull-based surgery, if I may say. Any questions, comments?
It's a beautiful, I recollect the incident of transfalcine opposite. Do you remember that? 35 years ago, he presented that paper in Manipal. Professor A. Raja was there. And I was the first person to ask you the question. He asked you the question was very simple, because that was revolutionized, as he said, the word. But suddenly somebody says that you say right side tumor, you approach through right side. Why is this man trying to put a flap on the left side? But practically, if you see, the dura is well mobilized to the superior sagittal sinus from the opposite side, then from the side of the tumor. The first question I asked you at the time was, did you study the venous drainage system? You remember? The same thing he said that, Pati, right, if Al-Mufti does that, probably you believe, but if Atul says that you won't believe, I said that no, of course. Then Dr. Raja came in, Professor Raja, you know, our doyen of vascular surgery those days, Professor Raja came, and then, believe me, still it is there. The word you said about 35 years ago, it was, I think, National Congress. It was National Congress, and we discussed this. I still believe there is one of the very good technique, but we are not doing it. Particularly the tumors which are just below the sinus, superior sinus, go from the opposite side. It's much more easier to to excise it, particularly from the non-dominant side. Am I correct? Atul?
No, see, this transfalcine approach, just, the beautiful thing is the thinking process. I'm not saying you just find out the right side and start doing from the left side. The indications are very far and very few, very few. To the extent, we discussed this transfalcine approach in 1995. And if you ask me how many cases you have done over the last 30 years, I will say not more than 2 or 3. I have done some AVMs after that, not tumors. So it is you have to decide for which case it is necessary, which case it is useful, and which case it is better than ipsilateral approach. You cannot start thinking and doing and taking from the left side. Imagine if there is a tumor on the left side, it has created hemiparesis, and you start coming from the right side, you damage the right side and you create a left hemiparesis. See, you have to be very, very cautious. Neurosurgery is indeed, you have to think in neurosurgery. You have to be intelligent in neurosurgery. You cannot be a, happy-go-lucky. You have to be thinking about neurosurgery. Every case you have to know which approach is the best, which approach will be the quickest, how to reach the lesion in the quickest time, how you remove the tumor, how you demolish the tumor, how you dissect the tumor is part of our life. Most important part of our life is hemostasis. How you, when it bleeds, how you react to that situation. Some people will start taking cautery and start burning. Some people will keep shouting. Some people will, start using clips and all those things. It is not like that. How you compose your own self, how you manage a bleeding situation, how you control bleeding is a part of our huge life that we have got. So bleeding control, dissection, tumor dissection, arachnoid dissection, all these things are so critically important, and they make make us. So enjoy neurosurgery and keep on working hard. Thank you very much.
Thank you, sir. And it's our pleasure to invite Dr. Manas Panigrahi, the President-elect of the Neurological Society of India.
Dr. Manas Panigrahi, he is the President-elect of NSI. He was a professor at Nizam Institute, Hyderabad, and he has contributed immensely to neurosurgery and training young neurosurgeons, and he is continuing doing the excellent work at KIMS Hospital, Hyderabad. Kindly join us, sir.
Good morning. I'd like to thank I'd like to thank Dr. Ipechiri and Dr. Ramdas and Dr. Sahana, who kept on pestering to me to come as I had some other meeting that was cancelled. And my family was very happy that I can enjoy at home. But then they pestered to come and they kept on changing my flight tickets and accommodated with all my requests. Ipe has been a friend for many years, and actually I wanted to come only for 19th on Monday, but then he said come on 16th so that everybody can listen what we are doing. As Dr. Gilbert said that when we read, we retain only 10%. As Professor Goel told all his history, means I also finished my neurosurgery in 94 and saw that his publication first was in 94. And I read all those. When we read, you only understand 10%, but when we listen, at least we retain 30 to 40%. And so that is the power of teaching. And unfortunately, we only think of train the trainers, like we only make courses to train the teachers, but we do not incorporate in our residency how to teach. We have seminars, we have journal clubs, and when the resident does a seminar journal club, we expect him to teach the faculty rather than the residents. But after they become a teacher, we expect them they have to teach the residents. So they have to be taught to be teachers during the residency. They have to teach the residents rather than the faculty, and faculty should not react when they tell that, oh, no, you are not telling anything advanced, you are not told the recent things. We have to encourage them that when they teach, 90% of residents should understand. Whether faculty understands or not, I think it's immaterial. I don't have so much of volume of work as Professor Goel. This is a small pilot work of using augmented using augmented reality in navigation. I'll also explain what is augmented reality and what is virtual reality and how we use in day-to-day practice. Now we use navigation, all of us, every center has navigation, many companies has, but in navigation we have to, everything is done under anesthesia, and you have to register, you have to mark the flap, all those takes time. And here is a technology where the marking and everything can be done at bedside. So when you go to the theater, patient comes with the tumor marked on the scalp, so that the surgical time comes down because you don't have to use navigation. So how to do away with this navigation system, and all of them usually have to have a frame based, or you fixed with a frame. Though in children we use frame, the electromagnetic one, but 90% of the time we use again frame based, which again adds time to the surgery. So these are all time wasted in fixing a frame, then doing registration with tracing skin markers. All those are under anesthesia. Now, if we can have a technology where we can preoperatively in the bedside superimpose the tumor on the scalp, mark the flap, mark your the flap according to the tumor, so that you can make a smaller incision, and patient comes to theater, anesthetized, and straight away you go for surgery. So the cost of treatment comes down because the anesthesia time comes down. Now this is different from virtual reality. In all anatomy department, what we use is virtual reality. Virtual means there is no patient, no cadaver, but we see the anatomy, go through the anatomy. It's like going through a time tunnel. But in augmented reality, you project your anatomical structures on the real patient. So this is what is virtual reality, what we are taught in anatomy. But if you have a tumor like this in the thalamus, and then this is what is augmented reality. The patient, the first patient is scanned, 360-degree scanning is done of the patient head, both the face, ears, and the posterior part. And all the pre-op images are are already fed in the software. And then you can superimpose the bone, the arteries and the veins and the tumor on the scalp of the patient. All these are done at bedside. Here the color of the vein is red, but because it was one of the first cases we have done, and the blue color is the tumor. So in bedside we can make out that which is the safest trajectory and where to make the flap to do the surgery. This also gives confidence to the patient relatives if they are around that we are doing on the correct side. We don't do right-left disorientation. Many times when you do a posterior approach, we can make mistakes of right and left, but this one assures that we don't do that mistake. So what is this frameless, pinless, ultra-portable navigation? What we need is just this device. SKIA device is like an iPad, and then one has to do a 360 degrees scanning of the patient. So the patient has to be cooperative in standing still. It takes 5-6 minutes. And then all the features from the, initially we used to use only nose and eyes, but then the accuracy was not so good. Then we started using ear, the nose, eyes and the chin also, when the accuracy increased. And that is with the AI algorithm, it integrates the MRI, not MRI, the CT scan and the CT angio onto the patient. So this is how it is done. We scan the patient and then superimpose on the patient's scalp and mark the flap. You can mark the frontal sinus to avoid. Suppose one is doing a supraorbital craniotomy, you can mark the frontal sinus. You can mark the sagittal sinus. You can mark in a retromastoid, you can mark the transverse sinus and sigmoid sinus, so that you can plan your RMSOC also. So this is what is done. Over this 4 months period, this is a pilot study, we have done 72 cases. This is a US patent Korean device, but they have used only as an education tool for the patient, which now we are extrapolating it for using in patients and avoid navigation. Most of the cases means you have done both of all ages, though doing it in children. In children, we have to do the scanning under GA because children, it's difficult for the child to keep the head in still for 5 minutes. So in children, we do it under GA, the scanning, but without pins. And most of the cases what we have done is supradental meningiomas, but we have done some cases of STMC bypass also. I'll explain how we use it in the bypass. To validate the accuracy of this, we did combine with navigation, like using standard navigation to see that the accuracy of the marking done pre-op is accurate with the navigation what we used, which is the gold standard we accept. So this is what we plan pre-operatively, the shortest distance from the tumor and mark the flap. And you can see the axial cuts of the scan. You can extrapolate, see that your tumor, what you see in the scan and the marked picture is similar. To avoid the parallax error, one has to do both with the axial and the coronal plane and the sagittal plane, so that so the marking is done with 3D orientation, so that a parallax error is avoided. When you do with the navigation with Medtronic, usually it is in a single plane, so many times in parasagittal lesions you make mistakes. The accuracy is not good in navigation, whereas here, because we do in axial, sagittal and coronal plane, the accuracy looks better. And one can also do without the frame fixation on the operating table. And I think this is a parasagittal meningioma marking. I think the video is not opening, that's fine. And how do you use for bypass? In bypass, one can mark the STA and mark the MCA branches also on the skull flap, and then plan the craniotomy where exactly you want to do the anastomosis. So instead of opening dura, finding the cortical branch and then transposing, you can plan your craniotomy well. And to confirm that whatever we marked with our device, we confirm with the Doppler that the vessels are marked properly or not. This is just authenticating the procedure. So this is what the bypass, we have done 3 ECIC bypass with this technology, marking both MCA and the STA also. Of all the cases, we took an average, what is the average time taken for pre-op time? It came like 6 minutes for the pre-op time for scanning the patient. And identifying the data. As I explained, initially we used to take the only eyes and nose. Now we have started taking the chin to increase the accuracy. And the accuracy, as you see here, the initial with the eyes and nose, and with the chin, eyes and nose, it has slowly increased over a period of time. And the time to register over the initially used to take little longer time. Now it has come down to 6 minutes. And we matched what we did in navigation as well as matched with the Skia portable device, and we had a quite good matching of what we marked with Skia and marked with navigation. Though we don't have very large numbers to have a statistical significance, but because now we have done 72 cases, and we need larger number to show statistical significance. But it's in pediatrics, means we've done only 1 case, so that was very good, but in epilepsy. But when you look at the supratentorial, we have not got statistical significance, but there's a trend that it will give us a good localization. So of the 70, 25 cases were done with only eyes and nose, 40 cases with eyes, nose and chin, and matching was in 90%, and it increases, means the duration of surgery reduced at least by half an hour, 45 minutes, because the navigation time could be reduced whenever we have not used navigation. The problem here is when it's difficult in children, because children cannot keep the head straight, and the patient is not cooperative because you have to keep 5 to 6 minutes in still position while screening. Now what we are looking for future, because this is something which is done with the surface lesions. For deeper lesions, it cannot be used at present, but what we are working with a robotic arm where we can also use the pictures so that the robotic arm comes and fixes at the picture taken while marking the flap. This is what is in the research team, research level, and at present MRI, PET and functional MRI is not able to, cannot integrate. Now only we can integrate the CT angio or CT venogram, and what we are planning is if MRI and PET and functional MRI can be integrated, that will help further in planning the flap and probably can avoid awake craniotomies also. As I told, children is difficult to do, or unstable patients difficult to do. It's also a very good device for teaching. This advantage I've already used because we reduce the operative time. And it's always a very good device for the patient education. As you see here, patients attentively look at and they get convinced how's the tumor, and they get involved in the surgical process. When we come out, they'll ask how was the vessel, how was the tract, whether the planning was good or not. So, and if any complication is there, they're ready to accept because they are involved in the planning process also. So in a conclusion, it will probably avoid neuronavigation at present for surface lesions. In future, when the robotic comes for deeper lesion, it's a good education tool for a patient and good education tool for first-year trainees. The first-year trainee can mark the flap at bedside and then send the patient. It's not that he has to come to theater only to learn the craniotomy flap. And so it has a great future, and And if it comes out at a cheaper cost, it will be cheaper than navigation. That's what we are working out. So it will reduce the cost, total cost of surgery, because navigation cost comes down, the theater time cost comes down. Before I conclude, I'd like to invite all of you to the spine meeting in end of September at Hyderabad this year. Thank you for your attention.
What an excellent talk, Manas. In 2017, we wrote a chapter called Hypervision. It's in the digital anatomy textbook brought out by UNESCO. At that time, my vision was that instead of the scans being projected in axial, sagittal, and coronal planes, should combine all that and project it onto the microscope field. So with Zeiss, we worked a lot on that, but it was just 2D projections. But now, we are able to do that on the exoscope. This is something that we'll be showcasing. And that too, it's a company from Hyderabad, incidentally, so they have done it. And this looks excellent. This is one of the problems that we had. It's a LiDAR registration that you've done. And you have scanned and registered and then got the scans onto, as a virtual phantom to project onto that. It's an excellent thing. I think this is the future we've been dreaming. I see Dr. Goyal. I mean, the amount of work this man has done. I mean, it's it's truly amazing what he's done. The kind of range he has and the kind of work he's done for such a long time. So as we were just seeing that, and we have so many fantastic people gathered here. And I think all of us, if we exchange what we do in our lifetime, the repository of knowledge is going to be just massive. So I think this is what conferences should promote, and excellent work again. Thank you very much.
Thank you. Thank you.
Thank you, sir, for this excellent innovation. One thing which I want to just make a comment, that you are making the preoperative planning in the sitting position. And then all the procedures are being done when the patient is in supine. So for the pedunculated lesions or the lesions which have some stalk, do you think that you want to register in the prone position or supine position in the preoperative image?
Yeah. See, as I told, these cases we are doing for surface lesions only, because this is only for marking the flap. You the present technology, you cannot use it intraoperatively, because we mark the flap. So it's totally not replacement for navigation. For deep-seated lesions, you still have to use navigation until the robotic arm comes. But as you correctly said, in the supine and sitting posture, it differs. So we do scanning in supine also. But as you do in supine, the posterior part cannot be done. So that is why many of the cases for validation during surgery, we have done intraoperatively so that we have accuracy. But what as the accuracy in pre-op and intra-op, there is a difference what we have found that we are trying to sort out how to solve that. So what you pointed out is correct. We are also having what is marked pre-op and intra-op. There is a difference because of the shift, so that we're trying to sort out.
Thank you.
Yeah.
Let's welcome the WFNS President-elect, Luis Borba. Luis, before he became the WFNS President or anything, maybe 10 years or maybe 11 years back, I know him. We used to teach together in many conferences, especially in Russia, where we had more than one adventure. So Luis is a great friend, and thank you for coming down, Luis.
Thank you, sir. Our next speaker is Dr. P. Sharat Chandra, who is the former HOD of Department of Neurosurgery at the reputed All India Institute of Medical Sciences, AIIMS, New Delhi, for 22 years. Dr. Chandra has organized several international meetings to enhance epilepsy surgery outreach along with several invited international faculty. He has done an extensive work on epilepsy surgery and CVG anomalies. Sir is going to join us online.
Morning, everybody. Am I audible? Am I audible and visible? Hello. Cherian?
Yes, sir, you're audible.
I'm audible. Is my voice okay? Because from here, the voice is very low. That's
Yes,
the reason I
sir,
was
it's all
confirmed.
right.
Okay, so thank you very much. It's indeed a great honor to be part of this symposium, and I really thank the organizers of the KVV Neurocon. And there are so many great faculty present here. It's my loss actually that I could not be there physically because of some really personal reasons. And I really hope that I will be able to make it next time. And I really look forward for this. So I thought, once you hear talks from Professor Atul Goel, you kind of feel that there is neurosurgery, there is absolute neurosurgery, and then there is Professor Atul Goel. That is the gradation of hierarchy. But I will try to do whatever things I have innovated to show you how innovation is part and parcel of your development, overall development of neurosurgery, along with research, along with teaching. So they cannot be separated. But of course, a small slide of what we have been going through for the past 1 week. And of course, we stand with the children for the horrible tragedy that is taking place in Kolkata. So this is something which looks very unusual. It says a fascinating journey to find new cheese. And I will shortly explain to you what this is actually about. But there is a disclaimer that I'm not an expert. I'm just an humble traveler like all of you. And this is going to be just a few notes from my own journey. So I was always stricken by this small book. I don't know how many of you have read it. It's a beautiful book. In fact, I liked it so much that when I became an editor of Neurology India, I requested one of the senior faculty to write a commentary on this book. So fundamentally, it's a very small book, and I advise all of you, those who are not read it, to go through and read through it. So it's a hypothetical story about a cheese station where you had 2 people and 2 mice. And they used to come every day at 9 a.m. They used to eat cheese. They used to gossip, discuss something about politics, did the work, and used to go back home by 5 p.m. So it's now starting to look very familiar. And soon they started thinking that the cheese is going to last forever. And the story starts when one day when they come, and then they find that there is no cheese at the cheese station. And interesting are the reactions of these 4 people. So one person said that, oh, I don't like change. It's not fair to have change. The other person is startled by change, but he says, okay, since change has happened, I should move forward and then see what I can do best. And then there are still 2 other people who immediately get into action. They say, okay, this is what has happened. Okay, now let's move forward. Let's go into future. So this is the story of this particular character here, how with whom I identify. And I think most of us also identify. Most of us success people also identify, because when we have changes, initially we don't like it. But then we realize that we need to embrace with this change and we need to thrive with the change. And so this is how it started with me. So I thought I should show you a bit of my life's journey. So the question is, what happens now? So these 2 mice move out immediately in search for new cheese. And this person, how he stays for some time and then decides, okay, let me also make this journey. So let's go ahead in his journey. And this is the journey of how through the maze till he finds new cheese. So for me, innovation was something very, very esoteric. When I became a faculty at AIMS in 1998, that's more than around 25 years ago, I always used to wonder, why is it that most innovations come from Western countries? Why is it that all textbooks of medicines only have Western names? I don't find a single Indian name. Why is it that anybody from India cannot actually develop a paradigm shift or some kind of innovation which would actually come into textbooks? And this used to bug, because we used to read so many things, this triangle, this syndrome, that syndrome. It looks as if almost everybody from the West have had discovered something which has gone into textbook. So I decided to innovate a small disposable endoscopic carpal tunnel set. And I worked with a local company. I created this. I got a clearance from the ethics committee, and then we would do surgery bedside with 2 small sutures. And we did more than 600 surgeries. We published a paper. We also patented it. But unfortunately, the issue was getting a commercial partner. And by the time we got commercial partner, there were similar products in the market. And then I realized the most important part of innovation. If you have an idea, you need to implement it as fast as possible, because time is of essence. Otherwise, somebody else is going to snatch that idea. But of course, I really enjoyed the process thoroughly. So this is very synonymous to what happens to How. So as he goes around, he finds that his earlier friends have left him some clues to find new cheese. And he gets a lot of insights, a lot of philosophical insights, which relates to his own growth. So one here, he says that the quicker you let go of old cheese, the sooner you're going to find new cheese. And having cheese makes you happy. For me, this was relevant here. Because when I did an innovation on my own, even though it was not commercialized, but I was so happy that I could finally do something on my own. And it had made maybe a small difference, but it had helped over 600 patients. So we moved ahead. And then, of course, I was really inspired by Professor Goel's paper of CV junction, which has, of course, a landmark paper. And then I started thinking, how could we actually develop a technique for such severe bacilli invaginations? Because here, only distraction is not enough. So even though this is a transoral which has been done by me more than 20 years ago, and I was very proud of it. When we got the CT scan done and we see this beautiful transoral surgery, I was very proud of it. But today, if I have to see a case like this, I would be very sad, because I know it could be easily fixed from the back by reducing the. So that is where we developed the technique of DCR, which stands for distraction, compression, extension, and reduction. So the fundamental idea is to put a spacer and then apply compressive forces for OC1 and C2 so as to lead to a complete reduction of not only atlantoaxial dislocation, but also the bacilli invagination. So that was a fundamental idea, to convert this pivot, this spacer, into some kind of pivot, just like Hercules here thinks of, I'm sorry, not Hercules, but this is, forgetting his name, lifting up the earth with the help of this, Archimedes. So then we, of course, we did this technique in more than 600 patients, and then we published a number of papers. That was the first paper which was published. And these are some more papers. And again, a few more papers which completely consolidated and established this technique. So everybody in my institute now does this technique, most of them. And then we published this hypothesis to show that there's a combination of weak ligaments as well as sloping joints, which predisposes this group of patients to AAD as well as bacilli invagination. And this happens because of the mutations at the level of FBN1 gene, which was once again reported for the first time. And we showed that most of our patients actually had a milder version of Marfan syndrome, which was leading to them developing this kind of deformities. And again, a few more papers which we published. So fundamentally, this is how it has been done, how you can reduce such severe anomalies. So most of the anomalies which are treated are very, very severe anomalies. I do them at least once a week. And you can see, you can provide a beautiful reduction using this universal reducer, which we have developed. Again, another example, pre and post-op. Another example, you can see that's the pre-op. The dens is almost turned backwards, and that's the post-op, where we have a fair degree of reduction using the universal reducer. So this was the old cheese to do a transoral. The new cheese is to reduce this deformity by doing intraoperative manipulation, which we had described again for the first time. So now, following this, we developed a new technique where we used a modification of DCR to reduce patients who had chronic displaced old fractures of the dens. Now, in our center, we do get some patients who come with this. So here we describe drilling of the complete C1 parts and replacing the C1 parts with a spacer. So we replace that with a spacer and again use the technique of DCR in order to reduce fracture dens. So you can see it's such severe anomaly where the logic would dictate that we have to do a transoral, but we were able to reduce it by using a modification of the DCR technique. And that's how it's been reduced again. So again, a few insights from How, saying that if you move into a new direction, it will help you to find new cheese. And that's where, epilepsy happens to be my other vertical where I'm interested. And here we developed for the first time the endoscopic technique for doing a hemispherotomy. And this was, these are the papers we published, and this went into all the textbooks, including Professor Jerome Engel's textbook of epilepsy, which is considered as a Bible for epilepsy. So we used a very small footprint using a craniotomy opening of 3 into 4 centimeters and ended up doing a hemispheric disconnection. So these are few examples of endoscopic hemispherotomy. So here you can see that beautiful disconnection. In this case, only 40 cc of blood was lost. This was a patient I operated in Malaysia. And you can see it's a very complex case of hemimegal with aplasia of the frontal horn where we did endoscopic disconnection. The child was having about 200 seizures a day. And using this as one of the fundamentals, we created other caveats like endoscopic assisted corpus callosotomy with anterior hippocampal and posterior commissurotomy for a subset of Lennox-Gastaut syndrome who had severe epilepsy. And this again was described for the first time doing an endoscopic assisted corpus callosotomy along with commissurotomy. Commissurotomy was being earlier done by Glure in 1960s, and then it was given up. But again, we were the first to introduce the concept of combining with this corpus callosotomy for certain subset of patients who had severe drop attacks. And using this, we were able to provide 100% relief of drop attacks and a significantly large number of seizure relief, 56%. This was a child who came from Yemen, from the Wonton area of Yemen. A child was having about 300, 400 seizures. She was roaming all around the country. And then finally, when we did this technique, the child became seizure-free. And the PR section of AIMS, they decided to publish it in papers. So now various places in this country has taken up this endoscopic technique. I will not show the video for lack of time. And however, we demonstrated that endoscopic technique was a safe, minimally invasive technique, and we started doing it for all pathologies of hemispherotomy. But the question was, could we evolve further? And this is where I was having conversation with John Stern, who's the editor of the textbook of epilepsy by Professor Jerome Engel. And I was thinking upon a bloodless technique. And then I asked John, this was in Banaras, a conference in Banaras, and I had taken him to have the famous chart over there. So I gave him a couple of tablets of metronidazole, and then we went to have, we really enjoyed the chart there. And that's where I asked, John, I'm exploring an idea of a bloodless surgery for hemispherotomy. Do you think it's possible? And then John, who had heard my endoscopic technique, was saying, oh, that sounds quite amazing. Are you planning to use a smaller endoscope? So John is a phenomenal person. But then I realized that if you need to create new ideas, you cannot use the old beliefs. You have to use something which is totally new. And that's where we developed this bloodless technique of hemispherotomy for the first time in literature. We have done more than 35 cases, and this is what we do. And this has come out in the cover page of JMS. For me, professionally, I came from an era where we had a hole in the brain and we were able to create a line in the brain. And we have used it for more than 35 kids, and it came out in papers. It came out in the national papers also, Times of India. So this is how we used to do. We used to pass multiple trajectories and then do disconnections. But we developed the X technique where just using 5 to 6 openings, we were able to produce now hemispheric disconnection. And this is how you do. A single twist drill allows us to disconnect an anterior, middle, as well as a posterior and amygdala disconnection. For corpus callosotomy, we use 4 twist drills. So with 5 to 6 openings, we are able to produce a complete hemispheric disconnection. And again, another example. So the recovery here is amazing. So by the evening itself, patient is extubated. By next day morning, patient is on the bed and taking their food. So we have done in 35 cases for all category of pathologies, and the outcomes have been simply excellent for this. So I will again skip. But again, the best part is no blood loss, single sutures if required, and he produced this beautiful hemispheric disconnection. And this is how it looks. So we had a full team coming from Israel who learned this technique. Jonathan Roth and Edo Strauss, they stay with us for 1 week, learning the planning. And we did 3 cases when they were there with us, and now they are really optimal. They're really enthusiastic that they should implement it in Israel. And this is the case we did, where we just applied 5 sutures. You can see 5 bandages. That's the only thing which was required to do an hemispheric disconnection. And again, we also trained the biggest hospital from Indonesia, Dr. Sotomo General Hospital, which has over 2,500 beds. So then we also described the robotic technique of disconnection for hypothalamic hamartoma presenting with gelastic epilepsy. So we use this robotic to use bilateral trajectory, and you started doing robotic guided disconnection. These are the papers which we published again for the first time in the literature. So over here, we started learning that it's sometimes you are overcome by a fear, a sense of apprehension that are you doing the right thing? Then you get criticisms from your colleagues, and then some of the other people, you may encounter some failures initially. That makes you think, should I actually go on this road or should I go back? And that's where it's important to realize that it's safer for you to search in the maze than to remain in a cheeseless situation. And that's what I decided. I decided to go ahead. We created a new retractor for endoscopic pituitary surgery. So we have all these equipments. I think most of them are not required. And then, there is always a high risk of atrophic rhinitis if you do biportal. And that's where we created this easy track system by which you can introduce it through a single nostril. And again, I will not go through the video, but these are the kind of tumors now I remove using this kind of retractor. And then we also described for the first time the technique of absolute alcohol embolization for hemangioma with single level fixation, by which we were able to treat large vertebral hemangiomas presenting with myelopathy. And treating this, we found that we are able to completely cure the patient. There is no recurrence of the tumor, and there is new osteogenesis, and these patients again have excellent outcomes. So the same day they're operated, the patient feels improvement in the same evening. And these are some of the papers we published in this direction. And it's extremely cost effective. It's just less than 2. In fact, it doesn't cost you anything to do an absolute alcohol embolization. And this was a wife of a reporter who published this article. So she had a term pregnancy, 30 weeks. She underwent a laminectomy somewhere else, became paraplegic. So we operated her in lateral position, fixed we did absolute alcohol embolization and fixed the spine, following which she improved completely. She delivered a very healthy baby and now is a very good tennis player and also goes to gym. So sometimes we do get into dark corridors, and that is where we become slightly apprehensive. But when you stop being afraid, like Dr. Atul Goyal, that is where you feel good. So for me, the darkest corner was, could I actually create up a facility for basic neurosciences research? Because that is a big challenge. Me being a very busy neurosurgeon in a tertiary center operating 4 to 5 days a week and having so many cases, so much of teaching, could we be able to create a good research paradigm? Because that what is some of the things which is missing in our country. And that is where I was fortunate enough to get this big grant from Department of Biotechnology from Professor Bhan, who is unfortunately no more there. And then I had a lot of encouragement from my mentor from UCLA, Gary Mathern, and Professor P.N. Tandon. And with their help, we were able to create this first center of excellence for epilepsy, which had these 4 verticals, including for the first of its kind of MEG center for India, along with, of course, there's one more center in Bangalore with a clinical electrophysiology lab, epilepsy surgery facility, and the first of its kind of a neurobiology center. So we did MEG in more than 3,800 cases. We developed various advanced algorithms for this. And we, of course, created our own SCG protocol where we record spontaneous seizures and also produce habitual seizures by stimulating, and then finally produce SCG guided radiofrequency thermocoagulation. And then we published this landmark paper in NEGM, which has more than 1,000 citations. And this is the first NEGM paper from neurosciences in India. And like Dr. Goyal says, it's not easy to publish from India because, people do look at us with a degree of, skepticism. So they really think, are we capable of doing this quantum of work? And to publish in NEGM, it's like the ultimate, has an impact factor of 175, but this became a landmark paper. This was the first paper for pediatric epilepsy, drug-resistant epilepsy in children, where we showed not only a 10-fold improvement in kids who undergo surgery, but we also showed that kids need to be operated as early as possible in order to prevent epileptic encephalopathy. And then these are some of our papers. We have more than 200 papers now, fortunately, with a very good team in the research, who work as research faculty. We were able to answer some of the key questions like the pediatric cortical dysplasias, the role of GABA and NMDA receptors in epilepsy, the role of dual networks for epilepsy, the role of non-histone substrates for epilepsy. And these are some of our papers which we published in high impact factors like Nature, Science Report, and so on. And then this is a very high impact factor publication on a MEG, showing connectomics in MEG. We also described new biomarkers like KYNA, again published in very good journals. And then we also went into AI, where we were able to create algorithms to find out the networks, origin and spread of networks in the brain, which became a very good add-on tool along with magnetoencephalography and other investigations. And now we are working upon this actively. So now all of you would have understood that cheese is a metaphor for what we want in life, whether it's a job, relationship, money, big house, freedom, health, recognition, spiritual peace, or even an activity like baseball, basketball, or running. And each of us have our own idea of what cheese is. And we pursue it because we believe that it makes us happy. If we get it, we become very attached to it. If we lose it, sometimes it could be traumatic. And maze is where you spend most of your time looking for this cheese. It could be your organization, it could be your relationships, it could be the community you live in. Sometimes the corridors and chambers contain delicious cheese. Sometimes the corridors are dark, and sometimes you can run into dangers. But overcoming this makes you or helps you to become a better individual, contribute better, and make a difference to people who are around you. For me, this is my maze. This has been my maze for over 25 years, where I have been running to find cheese. And I hope I continue to get more and more cheese as a promise. So finally, the book ends that how did find a cheese station with Sniff and Scurry, the two mice, and they were very happy because they had lots of cheese. And the question was left open, what happens to him? The book says, hopefully he should have made it. He should have followed the clues of how. But the question is, do I have 5 minutes time to conclude this? If I don't, I will conclude it immediately. Okay, I will take about 2 minutes.
Yes, go ahead, sir.
Please go ahead, Sharath. Please go ahead.
The question is, what would happen if he did not find the new cheese station? What may have prevented him from moving out and searching for new cheese? What could have still made him feel attached to the old cheese station, which doesn't have any more cheese? So I think these could be the three factors. The 2000-yard stare, giving too much attention to the narrative brain. That looks very complex, but I can make it very simple for you. So the first is the 2000-yard stare. So if you look at this portrait, it's called as the Battle of Britain-Field. And it looks, absolutely, it looks as if the King of Switzerland is absolutely in control of all the armies. But that is how the battles are not. When you do surgeries, you come across bleeding, and then you have to deal with massive tumors like this, hemangioblastomas. There will be a lot of issues. There can be a lot of unpleasant situations. So battle is not always completely planned. When you go out to war, you have to be ready for unpredictables. And this actually shows a greater truth about neurosurgery. It's called as a 2000-yard stare. And this is a painting which shows the horror on the face of the soldier when he faces the battle in reality. I think that is what happens to all of us as neurosurgeons. We come with hopes and aspirations that we're going to find the seat of soul. We are going to know how the brain functions, how it is complex. But somewhere we are overwhelmed by the quantum of work and the type of work we do. And that is why I think the first goal and objective is acceptance. The second is, of course, a bit longer, where I would say don't give too much of attention to your narrative brain. And this was a Nobel laureate who came out with an idea that we have two parts of a brain, the narrative self and the experiencing self. The bottom line is we have very little experiences, but then the narrative part of the brain creates and weaves a fictitious story around it. And that's the reason we should not give too much of attention to it. And if you look at this path-breaking discovery by Scott, by these two scientists from Germany who have for the first time described readiness potential, that shows that we don't actually have a free will. And that brings us to the question, who are we? The question is, we are nothing but the stories created by our narrative brain. And that's where I think the importance of awareness. I think that should be the next goal when we go on this journey of neurosurgery. And finally, we have this Don Quixote syndrome, which you could have read about it. The question is, sometimes we get stuck to a lie. We start telling a lie and we think that this lie is the truth, and we keep on repeating this lie again and again, as has happened in the First World War, where Italy was on the lie that it should liberate its cities, Trento and Trieste, and it lost about 700,000 soldiers. And that too happens in neurosurgery. For instance, the lie of psychosurgery, where it was used and overused in thousands of patients, still had to be abolished. So the third important thing, I think, is insight. So these are the three important factors which I think should allow us to go ahead in the path of innovation. Acceptance by confronting your fears, awareness by looking at things objectively, and insight to learn early from your complications. So these are the few humble contributions that we made, starting with an endoscopic carpal tunnel, to the DCR technique for CV junction, through minimally invasive techniques of epilepsy, including the Roche technique, a new retractor for endoscopic pituitary surgery, an absolute alcohol injection for vertebral hemangiomas, over 200 papers in basic sciences for epileptogenesis, one possible biomarker to treat epilepsy. So with this, I will end my talk and again thank for giving me this opportunity where I was able to share with you some of my life's work. Thank you so much.
Thank you, Sharath. That's an excellent talk, and probably the first time I have seen you compiling everything and putting a lesson to it. As you said, I see that 5/6 of the population, what Sharath told, what 5/6 of the population is doesn't reside in the West as such. We have compiled here some amazing innovators, starting from Professor Goyle, Louis, who still is, although he is West, but he's not really the West. So he is from Brazil. And then we have Charlie here, who's one of the most maverick surgeons that I have seen, and amazing at that too. So we have many of them from India, Manas, Ramesh, Subodh, everybody here I see who are amazing people who's done things in their own right, which really deserves to be, talked about. We have Dwaraka, we have Sampath, and so many more people who we are proud of. And then it's just that we don't publish or we don't present it the way that we should. And I think this is an eye-opener for all of us, that we stand together. I mean, we all have our fears, and sometimes what these fears do to us is that they make us more mean people. So instead of that, if we understand that these fears we are facing one common enemy, and these fears are there for everybody. And so we don't have to worry about the next person with us. All of them are facing the common enemy. So if we can be hand in hand, and if we can be kind and less mean to everybody, and have less hierarchy and have a little bit more of fun rather than being headstrong and egoistic, I think that will go a long way towards taking neurosurgery. That would be the real paradigm shift. That would be the most important chapter that we can do to change neurosurgery. With all these fantastic teachers and their eons of experience, I think that's what can gift us for that. So thank you very much, Sharath. Fantastic talk. Any other opinions and comments, please? And we would invite Luis Borba to give a talk right now. Yes, Luis, you're on, man. So Luis is having a tough time because he came today, and as usual, Luis expects crazy things from me. So tomorrow morning, he's going for the waterfall And so, and tomorrow evening he's flying. So we are not allowing him to sleep for about 3 days. So he might as well talk right now. Anybody else? Manas, Professor Goyal, or anybody would want to say something on this?
Sarathi, there is no question you are doing some fantastic work. You are working in a fantastic institute. That maze of yours is indeed a maze of anybody's dream. You enjoy that dream. You bring that dream into life. You keep on hunting. You keep on struggling. And you must reach your destination. And you have already achieved what you have achieved. But still, there are miles to go before you or any one of us can sleep, and sleep happily and peacefully. My best wishes to you, my dear Sarath.
Thank you, sir. Thank you so much. Really means a lot to me.
Thank you, sir.
Now, I would like to invite our next speaker, who is Dr. Louis Borba, who is the President-elect of WFNS, and he is also the Professor and Chairman of Department of Neurosurgery at the Federal University of Parana.
Certainly. Luis is from Brazil. Luis, he's a young man from Brazil, older than me, but very young in spirit. You see, he has traveled all night by car. He did not expect a 7 hours car drive, and he just arrived in the morning. Enthusiastic young man, very energetic, and very phenomenal and colossal neurosurgeon. He's not just World Federation President-elect, but one of the finest neurosurgeons. He has worked hard to reach where he has reached. He has done extensive anatomical dissection in Al-Mefti's lab, where I first saw him in Arkansas, where he was continuously dissecting. And he was enthusiastic even in those days. And he wanted to do big. He started arguing with Al-Mefti. He used to start arguing with everybody on the planet. He used to talk on petrosal approach at that time as a young man, 30 years ago. And then, kept on working, kept on doing fantastic things in Brazil. He's now he has achieved what he has achieved. And what he has achieved is like he's now the president-elect of the biggest society of neurosurgery. So welcome to you, my dear Luis, to this city. And I hope you enjoy your one day. He came today morning and he's leaving tomorrow, all the way from Brazil. So let us give a big applause to my dear
Luis. First of all, thank you very much for the opportunity to be here. It's a long trip, and I really enjoyed to come to India to see Professor Go, my friend. I'm cheering in all of you. This lecture is not for you. I see a lot of seniors, chief neurosurgeons here, very experienced. This lecture is for the young neurosurgeons. But this lecture that you send home to your department and see what's happened today. And we, as a neurosurgeon that started this journey a long time ago, with the passion, determination, now the people looks like it's changed. I don't know how it's in India, but in Brazil, in many places in the world, the way that they see the neurosurgery, the way they see the medicine. the way they see as a doctor is different. I come from a city in the south of Brazil, you call Curitiba, in south. It's one city, 3 million inhabitants. It's like a small region here, a small town in India, in the south of Brazil. Brazil is a continental country, but Amazon is like the size of Europe, but has no more than 3 million inhabitants. And the people say that the Amazon is disappearing because the people doesn't know what is Amazon. It's 90% complete preserve. What you see in the news is more news than our politician than another thing. Be safe, the Amazon, the lung of the world, will be alive during many, many, many years and centers, I think so. Harvey Cushing, 100 years ago, more than 100 years ago, 120 years ago, he said, nothing is more satisfying to a neurosurgeon to do a radical removal, a meningioma or any benign lesion, and cure the patient. Cure, the word cure, with neurological preservation. It's our goal as a neurosurgeon, our goal as a doctor. At least try to cure the patient. Sometimes you cannot, but you need to try. Nothing is more satisfying to us when you have a case like this, a large meningioma in the cranioception junction. You do the surgery, we expose the lesion, you mobilize the vertebral artery, you go there and totally free the tumor in the cranioception junction, and remove the mass. And the guy that came to you in the wheelchair with tetraparesis, it can go and remove the lesion. And you talk now about cure, and the patient starts his recovery. Maybe nothing is more satisfying for a neurosurgeon and a doctor. A young guy came to you in the wheelchair, tracheostomy, gastrostomy. He passed several doctors from the public hospital, no money involved. And you spend 18 hours in the OR. You can go there and try and spend the microsurgical technique and remove the tumor, and not talk about the approach, not talk Petro's approach, nothing like that, and see the plan that was impossible to get. With time, with dedication, with microsurgical techniques. It's our life as a neurosurgeon. You can preserve all the structure in the post-op. After several days in the recovery, now this guy is back. He's back to life. It's our goal as a doctor. But the time is time. Time is changing, you are learning. When I started to study skull-base surgery in the 80s, in the 90s, in the 80s, or Professor Goyle, larger incision was better. As bigger you do, better you are. Now it's the reverse. The smaller you do, better you are. We need to find a point. In the point, you come to the classical. 80 to 90% of the skull-base lesion you can remove by a simple paternal approach using the cisterns, or the simple retrosigmoid approach using the view that show you. But does not mean that you don't need to know other kind of approach. You have to have an open mind. With the time you are learning. When you are young, you believe that you know everything. When you get some age, you know that you don't know anything. That you need to learn more and more. There is no way the guy say, this guy is the only one that can do. I like football as a Brazilian who like football. Our team now is not okay, but you can compare these two players here. 1994, Romario, I don't know. He never trained. He hates to train, but his talent was given by God. This other guy, Cristiano Ronaldo, if you see the video of Cristiano Ronaldo with 16 years old, 17 years old, you say, this guy will be a simple player. Maybe not the player that he is now. But he trained 24 hours. He dedicated himself. He prepared himself. And all of you, young neurosurgeons, medical students, residents, can be Cristiano Ronaldo. Maybe Romario just Professor Goyle that have given by God all the knowledge. But we can be Cristiano Ronaldo, but if you dedicate yourself. For it, in any kind of profession that you do, we need passion. We need to love what you do. You need determination. You need to go and follow what you believe that should be done. You need focus. You need to focus in the direction that you believe that is correct. If you don't have these three words in your mind, it will be difficult in any kind of profession. Not as doctor, not as neurosurgeon, any kind of profession. This is my first temporal bone, 1993, December 24, the night before Christmas. Do you know what's happened? Dr. Omlefty didn't have a good relation with ENT. Charlie still knows very well. And there was a very small lab, just one microscope in the ENT department that nobody could go there. But the lady, I was living in the dorm of the hostel. The lady that was cleaning the dorm was a Cuban lady, very nice lady. But it was the same lady that was cleaning the ENT department. And I told her that I knew that there is something there in the ENT department. In December 24, nobody was there. And she opened to me the lab. I couldn't find the labyrinth. I couldn't find the facial nerve. I couldn't find anything. Just the bottom of that. I pushed through the temporal bone to the other side. Was in that time I couldn't find anything. It's very difficult. But I didn't give up. I tried to continue and talk with the lady, and during the night, sometime 3 o'clock, 4 o'clock in the evening, was there trying to dissect the temporal bone, try to learn. Now I have more than 1,000 temporal bone dissecting course in surgery, and I learn a lot in this area. The neurosurgeon should have an open mind. Every day there is a new approach. Every day there is a new way to see some pathology. But does not mean that this new one is the best one. We need judgment. Have to be critical. It is very important today. Today you see every kind of approach is coming from the nose, from the ear, from the eye, from the throat. Everyone. Neurosurgeon like that. See? He cut a little bit of bone and put his name. New approach, try something. Neurosurgeon need to take risk. Always you need to take risk. There is any specialty as a neurosurgeon that every surgery that you do in cranial, you can leave your home smiling, you can come back crying. Because every case is different. But you need to take risk. If you don't take risk, you don't advance. You'll be always in the same position forever. When you take risk, you can go ahead. We need to understand that the natural views of the brain, of the nervous system, are the best way to reach. See, the best way to reach any kind of pathology in the center, in the nervous system, are the sulcus, are the cisterns, as the natural view. Imagine if you go to Venice, in Italy, you go take building by building, don't use the channels. God gave us the channels. And to use these channels to make our approach. Professor Yashagil, I will say, every approach needs one system. In this system, you open and relax the brain, it gives you the view for any kind of position, in any place that you want to reach. You cannot do anything alone. We need mentorship. We need somebody. We need that as a whole model, that you believe, that you trust, not only as a surgeon, but also as a man that you can trust. You need to define priorities. That to be in the neurosurgeon, to be neurosurgeon is very difficult to you. You spend 18 hours in the OR to get the tumor and to try to cure the patient. It's difficult to you. Change your job. Go to another job. Maybe you'll be happy and make it better. Nobody does anything alone in neurosurgery. We need partnership. We need the team that help you. Team does not mean many neurosurgeons. Team gives a good anesthesia. The lady that is in the room, the scrub nurse, always part of your success. And the most important is, be happy. If you are a neurosurgeon, if you are a doctor, you're not happy, it's a problem to you, change your job. Yeah, it's not to you. The education today depends on you. There is good educational program, there is not so good educational program, but you can make your educational program. Today, the knowledge is universal. You can go to the YouTube and watch Charlie Steele doing beautiful case. You can go to the Zoom and watch Professor Go and Professor Shirian. You determine your future. You can do. Nobody will do for you. Just you make yours too. Today you have online, on-site, hands-on, simulation, models, every kind of methods to learn. The Zoom, the pandemic, the terrible pandemic time, gave a great opportunity to education. I think the education neurosurgery can divide in before pandemic and after pandemic. In pandemic time, you have the opportunity to see the best neurosurgeons in the world at your home, on your TV, giving lecture half an hour, 1 hour, sometimes you stay 3-4 hours watching good case. I remember people that when they call me from Bangladesh, I say, Dr. Borba, you wait 3 o'clock in the morning to see your webinars. You know, the people was there, 1,000 people online. Now you see Professor Go around the whole world. In the whole universe, you can see the king of Zoom. But does not mean that you be a neurosurgeon by internet or by Zoom. See, we need to go and see. We need to visit and see in loco what you want to. You need to travel. You need to go to see the guy doing his surgery, his movement, how he's doing. But more important than this, we need to train. Train in the best way is go to the lab. The lab is the best way to learn neurosurgery. There is no more time to learn in the head of somebody. We need to train first. We cannot train in the people. We need to train and simulate it before. We need to trust in the people. We need to trust in the teachers. We need to trust in the people that has experience. This is one example. This guy here from China has 1,546 petroclivomeningioma area. Not new, in the area of the petroclivo. In more than 50% they use transpetroso approach. Does not mean petroso posterior, anterior. He used the temporal bone. He cut part of the temporal bone to reach. Now somebody say that you don't need to learn temporal bone. You don't need more transpetroso. You don't need anything. Do you know why you don't need petroso approach for petroclivomeningioma? Because 90% of the posterior fossa meningioma are not petroclival and are described as petroclivomeningiomas. Are petroso, anterior petroso, posterior fossa, any fine. Only 10 to 15% are real petroclivomeningioma that is middle in the attachment, the clive is more lateral to the petrous. Because this you don't need. Because it's not selected the same way. Same thing happened for foramen magnum meningioma. 90% you don't need transcondylar approach. Because the tumor is posterolateral, is large tumor is coming out. It can come from the midline, the tumor look to you. But there is case. That is not everyone. Very few cases that you need to go lateral, that you need to come, maybe sometimes anterior. But does not mean that you don't need to know. You need to know the best way to do it. We need to believe, but sometimes you cannot mix medicine with business. This is the booth of the Lexel gamma knife in the WNS, the Americans, the big Americans, the largest meeting in the world. See, this is the tumor that is the example to treat with gamma knife. Imagine this. You can do this case on the street. It's very simple case that look at the attachment here, very small attachment in the tentorium. You just cut the attachment in the tentorium and the tumor will come out. Like in this case here, you see? Very similar situation, very small attachment. You just go there, go to the tentorium, you cut the attachment of the tumor, you free completely the tumor, now you have the ball that come out. No radiation, no necessity, any kind of thing, no control. Now we are changing the word cure for control. It's not the way. We are doctors to try to cure, not to control. Control is for the police, not to us. You can take this and get a good removal. No necessity. Critical judgment. Not everything that somebody can, with nice ties, nice shoes, say that he's better than us. Once again, there is no time to train in the head of somebody. We need to go to the lab and train and train and train. We need to do course. We need to go to the course. But does not mean that you go there during 3 days, learn one approach, and Friday, Saturday, and Sunday, and Monday, you do a case. You cannot do like that. You need to come back, open your mind. Maybe you go to the anatomy lab, maybe to study more. Have to be prepared. You feel prepared, you can do it. And the course is to learn, not just to show in the Instagram, in the Facebook, on the YouTube. Look at this guy here, see? This guy here probably in his office, the largest certificate to be in his office. This is the guy. I did the skull-based course, you see, but he was sleeping all the time. But he has the certificate. This is very important. The golden mind that you have is the anatomy. This cadaver here is the new one, very clean, $2,000. This here is not a new one, it's clean, it's free. Where is this? In the anatomy department. The one that is old, is sometimes dirty, is smelling bad, but you are learning here to save people. Here, maybe to make publications. Here, you learn as a doctor. Here, maybe you learn as a teacher. You can use simulation. Simulation is very good. Of course, don't give you the feeling, the complete feeling, but you learn how to manage the microscope, how to manage the clip, how to manage the instruments. You can do in any part of the world, in the hotel, in the convention center, in any part. Every kind of training is good for your development. We need a lab, but more than lab, see, is my lab in Brazil. You are using this technique with placenta. It's very difficult to get the cadaver in Brazil. You cannot cut the head, cannot separate, and you cannot buy. You have to buy from US. One come from US is very, very expensive. You see, you use the way to learn microsurgical techniques. One of them, very simple, with placenta. You take 2 placenta, put like that, fold. You can put a simulator here, you inject, and you can put in a 3D skull. Looks like a Sylvan Fisher. And you use the microscope, you use all the microsurgical technique that you use in surgery. But what is most important in this picture here? You see, man, this lab is very nice. You see, microscope, TV, monitor, microsurgical instrument. What's happening here? It's empty. It's empty. Just this guy is there. This is my resident, the 4th-year resident. He's there almost every day. During the night, after surgery, he go there, not every day, but every week he go 2-3 times to the lab and training. The other guys are very busy. They are tired, they are on call the other day, and the lab is empty. This guy will not be like the other guy. This guy will be completely different the other guy. Because this guy is spending his time, he wants to learn, dedication, and the thing. This makes the difference. Who is making this? Himself. He is helping himself. You give it the opportunity to the people, but sometimes the people don't want. Or they believe that they know everything that they don't need. It's very common in neurosurgeons, senior, resident, and sometimes medical student. They believe that they know everything. We need, in neurosurgery, strategy, know the approach, understand the microsurgical technique, and technology. Everything helps. There is nothing one against other. There is nothing technology against technology. You bring everything together. We need to plan. Now you can see, you can plan and do whatever you want. You can plan every kind of approach. And you need to study. If you study, if you dedicate yourself, you'll be completely different. Please take this message to your residents, for the young people that's there. Neurosurgery has to be a pleasure. I like a good wine, a good meat as like Brazilian. I like football. You see, here we are beating Germany, we are beating Argentina, that is good when we beat them. You love neurosurgery. When you love what we do it, your future will be bright. Thank you very much. Sorry for the long time. I became a priest now, no? Thank you. Next.
Now we have a message from the president of NSI, Dr. Daljit Singh, who unfortunately could not join us because of the ongoing doctor strike.
Hello, good afternoon. First of all, on behalf of Neurological Society of India, I congratulate Dr. I.P. Cherian and team for organizing KVV NeuroCon 2024. I'm very sure under the leadership of Dr. I.P. Cherian, Dr. Ram Das, Dr. Selva Pandian, Dr. Sahana, it's going to be a wonderful meeting, cherished with a lot of information about the knowledge about neurosurgery, skill development and various other aspects. I'm extremely sorry that I had to cancel my visit last minute because of the strike which is going on in all India level, and most of Indian students and Indian residents are aware of. And because the residents are on strike, it is the permission to leave has not been granted. So I really apologize for my being absent, although I personally wanted to be with each one of you there and enjoy this meeting also. And you may also notice that we are using the black ribbon as a protest and support for the just demand of the resident for the ghastly episode which happened in Kolkata a few days back. Anyway, I will miss the meeting. I'll miss all of you, all good friends from both India as well as abroad, and certainly would hope to meet some of you again soon in some other meeting. Best wishes. Enjoy your stay at Karat and enjoy the hospitality of the team, which is so good in catering all kind of services. Thank you so much.
Masters of Neurosurgery to have given us the exposition. And now the lectures will start in the other three halls simultaneously. During the break, you can have a cup of coffee and some cookies. And for this session, we'll be having the memento presentation session in a few minutes. And then the next session will continue in Hall A. For Hall B and C, I request the speakers and the interested delegates to go to the other halls.
After that, we will have a small tour of the new department, including the operation theaters. Anyone is most welcome. Debu and Ramdas will tell you.
This is for the invite करना है एक एक करके करना आप chairperson थे ना.
Can I request Professor Atul Goel to give us the opportunity to honor you?
Who's going to give it? Who's going to present?
Dr. Aip, can I have you to honor Professor Goel? Can I request Dr. Gilbert to please come onto the dais? Okay, you can announce the other one. Let me give it to Kazadi and Manas.
I would request Dr. Kazadi Kalangu to please come on stage. Right. Dr. Manas Panigrahi. Louis Borba. Dr. Louis Borba. Dr. Sharat Chandra's memento would be sent to him.
We'll be sending it to him.
Right. That's it. Thank you. So with this, we end the plenary session and we start the other halls as well.
Yeah. Okay. And the chairman for the plenary session second.
Right.
Just
invite the chairpersons for. Invite the chairperson. Yeah. Dr. Kazadi Kalangu.
There will be a small break for 2 minutes in the power because the generator is being shifted. Right now we're getting the generator on, there's an issue with the power. So that much time I'm sure we'll take to resettle.
In the meantime, we'll be starting the other two halls, Hall B and Hall C.
आईप सर बोलले आता हे संपलं हे तिकडे आहे मी कन्फर्म करतो
याला घ्यायला लागेल ना
कशाला
याला दोन दोन पॅच कोड घ्यायला
हो घेतोय की काही अप अँड डाऊन आले घेतोय की
छोटे मोठे
हो
इक्विपमेंट आहे ते
तेच काढायला घेतलं होतं परत लावतो
चालू करू काय करू
UPS टाकलं
मधून टाका
हा बोला की
मला वाटतं काढायला घेतले फक्त वायरी काढायला घेतलं
काही शिफ्ट करायचं ना
शिकूया खाल्लंच घेऊया
नाही मी बंद केला बटन बंद केली तिकडून आल्या इथनं बटन बंद केलेत मी हे बंद
चालू आहे
बंद केले बटन बंद केले तिकडला तर ते सप्लाय इकडं नाही
सेल्युटी पाहिजे का बघितलं
दोन मारू पाहिजे हॅलो हा आहे की तिथंच आहे हा समोर टी ब्रेक झालाय
Now I would like to invite all the chairpersons, Dr. Ramesh Sejla, Dr. Subodh Raj, Dr. B.B. Sinha, and Dr. J.K. Partiban.
स्क्रीन पता है क्या एक नंबर कौन सा
Hello. 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 Hello.
Now, I would like to invite the chairpersons for the coming session, Dr. Ramesh Tegla, Dr. Subodh Raju, Dr. V.D. Sinha, and Dr. JKBC Parthiban. Please come to the front. Is he online? Is he coming online? Is it connected? No, you can announce. You got it. Yeah, introduction. Now we are going to start the next session.
So we have our next speaker, that is Dr. Manuel D. Jesus Encarnacion, MD resident physician, who is a senior researcher of People's Friendship University of Russia. So I invite him to speak on the topic low-cost exoscope, and he's joining with us online.
Hello. Hello, everybody. Can you hear me?
Yeah, we are able to hear you, Dr. Ramirez.
Ah,
Yeah. Welcome, please.
yeah. Thank you. Thank you very much for this opportunity to present here in front of all my professors. For me, it's a huge honor. I'm gonna share right now my screen.
IP is just out. I think he'll be coming now.
Yeah, perfect. Can you see my screen?
Yep. We're able to
Yeah.
see.
Yes, perfect. I can start now, right?
Yep.
Yeah, fantastic. Thank you so much. So to start, I need to say there is no any kind of conflict of interest about the material equipment I'm gonna present. Secondly, this is not a microscope killer because as you can see, both way can take you to wrong. In this case, both way can take us to the good result of our patient, microscope or the exoscope. It's important to know worldwide there is a lack of places where we don't have and the proper technology for treat our patient, microscope, exoscope, and so on. Here, this is one of the pictures bring me a lot of ideas and shock me very hard. We'll see a neurosurgeon here using a local, a normal light source for make a procedure. So all this thought came to my mind. Then I think we thought we need to do something. So this is the evolution of our low-cost exoscope. This time we was using it in Kinshasa, in Congo. You can see here.
Dr. Ramirez, can you make it full screen, your slides? Your presentation.
You are seeing full screen, right?
We are seeing the complete, not the slide alone, but other things also. Can you make it a full screen?
Yeah, I'm making full screen. Okay, let me do it again. You see it now?
We don't see it as a full screen, but we see it as, yeah, now it is better. A little bit more full screen.
Oh, okay, perfectly. Yeah, now it's full screen, right?
No, there is this one down. If you can come down and see. Yeah, come down, down. There you can see that the screen there. On your slideshow.
Yeah, but here it's a full screen.
Yeah, that one. Yes, please click it.
Yeah.
Okay, fine.
You see full screen, right? Yeah.
No, we see
Okay.
the other
Thank you.
slides
Thank you so
also.
much.
Yeah.
Now you see full screen, right?
No, not full screen, but then that's fair enough. I think you can go ahead.
Yeah, it's because I see a full screen. It's strange. So, during a conversation, somebody asked me, why we need the low-cost scope if with $15,000 we can get a second-hand microscope. Then I say, everybody, all the neurosurgical department all around the world don't have $15,000. This is something we need to have in mind because we have a lot of devices in the market, but they have a big problem for the low income countries, and this is the price. As you can see here, $450,000 is forbidden price for a lot of places all over the world. So when I saw these prices, that was my expression. Then I even cried. Then we start to present this low-cost exoscope, and in the beginning, we struggle with a lot of parts. We start to use a microphone arm device, and it's important to know this is not the James Webb. This is not the James Webb camera. So don't expect we're gonna see another panel, something like that. So here we present in Kinshasa in 2023 our device, and as you can see, the working place, the working distance is 80 centimeters. We work it there 80 centimeters, and you can see properly how you can work. But remember, in this case, 80 centimeters is more than enough for prepare, for example, for pedicle screw preparing or something like that. Then where you have the threat of hit the microscope like. This is the model we try to develop with the power bank or the power battery, because this device is developed from our target is low-income countries all over the world, where some places have a problem with the light source. This is the first characteristic of our first device. Here we was using in some spinal procedures. And this is the time, the installation time of the setting time of the device. So the idea is, how much you think this can cost? Yeah, the idea is everybody can have this kind of technology. And you can ask, but in which cases I can use it? As $1 million answer is all neurosurgery. You can see neurotraumatology, spinal neurosurgery, neurovascular, neuro-oncology. This is one of the reviewer in one of the articles we submit. The reviewer asked us, $350,000 is the cost of the exoscope normally. Are you sure we are talking about the same? Yeah, and we was like this, like, yeah, we're talking about the same, because we need to go ahead with this kind of device and make it more affordable for everybody around the world. So let's get ready to rumble, and let me show you what we're capable to do with this. I'm saying spine here. For example, in ACDF cases, where you usually can use
Your
a loop.
slides are not moving. Ramirez, I think your slides are not moving.
Is moving now?
We are in the first slide, the current question.
Okay.
Yeah, now something is happening now. You can.
Yeah, better now?
No, we are with, I think, Rumble. Let's get ready to Rumble.
Yeah, let's get ready to rumble, because I want to show you of what our device is capable of. Here are some of the cases we made. For example, from TLIF cases is That was one of our first cases where we don't have a proper light source, and was
Your
hard
slide is
because we,
not moving, Dr.
yeah,
Amos.
you see it now?
No, we see only the let's get ready to rumble. That's the slide we are seeing. Yeah, now it is moving. Now it moved. I think, yes, now it is moving.
Okay, I put a big screen now. You see it now?
Yeah, now we can see one slide. The next,
Yeah,
that is 28th slide, yes.
yeah, perfect, perfect. Yeah, as I was saying, in the beginning, we were struggling with some spine cases because the proper light source wasn't enough. But over the time, we was involving, and we get to understand how we can make it better. You can see here more spine cases and ACDF. Do you see the video?
No.
Okay.
I think you have to
Now
click every slide.
you
Now
can
we
see
are
the
seeing a
video now?
video.
Yeah, okay, perfect. I'm gonna do it like that if we have some technical issues. In that way, you can see it and I don't make to waste more time. So as you can see here, this is a low-cost score where we're using in ACDF cases, for example, from ACDF for cervical cases is very useful. You see all the video, right?
Yeah, the video we are seeing now.
Yeah, okay, yeah, perfect. So you can see we make the discectomy, then we go, yeah, you can see we prepare the end plate after it, and you're gonna see the dura mater in the back, and you can see perfectly. It's better, more practical to use the loop. You can see here, yeah, in the bottom. The zoom in, zoom out is like with the telescope, and you can use also the camera to get more zoom and more zoom out. I will move from the next one. For some oncology cases, you can see here, especially we have a good experience using in spinal cases, though we don't need to move it too much. And our arm we're using now, we're still involving it. You can see the proper light source is crucial to get the good illumination and make it more easy. Also from some trauma cases, from cystonostomy here. From some cystonostomy cases, you can see here. Sometimes we use the Wi-Fi telescope, and we can connect in any table or any wireless screen. Some of our articles about the topic, let me show you here. Yeah, this is, you see my screen? Are you seeing it?
Yeah, we're seeing that comparative survey.
Yes. Oh, perfect. Okay, perfect. Yeah, thank you. So this is some of the experience publishing this low-cost exoscope. In some neurosystem psychosis cases we have the aneurysm cases. Let me show you the video here. You can see how clear it is, especially from the anterior circulation system.
No, we are not able to see the next slides.
Okay, let me put it. Yeah.
Yeah.
See it now?
Yeah, now we are seeing.
Yeah. So for the anterior circulation is very practical. Do you see here from the open all the sphincter in the anterior circulation we're using? We have humble experience. This is some of our cases. We have neurocysticercosis, nerve grafting here, for example. So something we figure out is in some cases, for example, in some spinal cases, we're gonna use the microscope at least 20, 30 minutes, sometimes in some disc herniation. So our idea was, in some places where you're gonna use a microscope, 20 or 30 minutes maximum, sometimes you need to use usually you need to use the back from the microscope, and a back from the Pentero or Kinebo is quite expensive, at least $50. $50 in daily, yeah, it can be not very friendly with the environment for the contamination. So this kind of technology, we can make this gas sterilization with xenon and formaldehyde, for example. You can see for the graph shooting here. The list of some of our cases, you already see the graph here. We have schwannoma also. This is all the equipment. You can prepare it in serum stick, for example, because you need to have a good eye. And of course, important, because this is not panacea and we are still evolving. We have pro, we have contra. Advantages is ergonomic, it's comfortable for the surgeon. You don't need to change position so much as the microscope. The first surgical assistant is also able to see and assist better because it's gonna see on the screen. It's not when you're using a loop, for example. Don't consume a large footprint in the operation room because it don't take too much spaces. Remember, in some places, the operation room is quite small, okay? From educational and training opportunities in the operation room to all the staff. The ability to scrub the nerves, participate more actively in the procedures. Of course, the limitation, the amount of reposition of the scope during the procedure is something we are still carrying it because we don't have an electric arm design, for example, not yet. The learning curve is, yeah, it's take time. Some possible vertical because this is not a 3D telescope camera, and the light source sometimes require additional lighting to achieve the high resolution. So in conclusion, remember the low profile exoscope allow for light operation of operative corridor. This is designed, it's not from, high incoming countries. This is for low incoming countries. So you can use the gas sterilization, making more environment friendly because we don't need to use a different bag. It's easy to move. You can take in your bag and that's all. And of course, here, a lot of people to thanks, because if I can start to mention all of them, I don't want to finish right now. And remember, in the end, one day when you are not here, you will be what you have done and in the way you change other people's life. Thank you so much.
Thank you. Thank you. Thank you very much, Dr. Ramirez. Thank you. This exoscope is made in Russia.
Making my balcony.
Huh?
In my house balcony is made.
Okay. Yeah. What is the cost of this exoscope?
Yeah, for all the parts, because in the beginning we start to get parts from Asia. Now we are getting from some part from Germany, and the cost is over $3,600.
Okay, that's nice. It's a good presentation. And
Thank you.
now exoscopes are picking up in neurosurgery. And certainly there are a lot of advantages there, and you have enumerated that very well. We'll be happy to have any other discussion would like to have. One second, we have one question coming up.
Hello, good morning. How much is your magnification in this exoscope? How much X?
The magnification is 5 to 7x.
5 to 7x. Okay, thank you.
Yes.
Is there any other questions here? Yeah, thank you, Dr. Ramirez, for a nice presentation. We're very
Thank you so
happy
much.
to listen to that, and it is extremely good to see systems of indigenous systems, and the concept has picked up phenomenally. And we neurosurgeons are used to microscope, but now we plan to have a combination of what the endoscopic surgeons were doing it. Now we combine that with our microsurgical skills. Thank you very much, Dr. Ramirez. Thank you for
Thank you
joining
so much,
us. Thank you.
Professor. Thank you.
Thank you, sir. So the session is over. Thank you, sir, for joining us. So now we are going to start the next session. So I would like to invite the chairperson, Dr. J.K.B.C. Parthiban, sir. Now I would like to invite the first speaker.
So I invite Dr. Ramesh Tegla, MS, MCH in Neurosurgery, who currently works at the Department of Neurosurgery and Institute of Neuro and Cardiac Sciences, Vijayawada, India. He has over 28 publications to take lecture on the topic Minimal Access Occipital Sinus Pairing Approach, Technical Nuisance and Case Series.
Good morning, respected chairpersons, speakers. At this outset, I would like to thank Dr. Cherian, Dr. Ramdas, and the team of KVV for giving me this opportunity. This is a small presentation where an approach can make a small difference to avoid some of the complications of the neurosurgery. This is a minimal access occipital sinus sparing approach, technical nuances, and some case series. Okay. So as you know that midline suboccipital approach, this is the main workhorse for the lesions which are situated in the posterior midline or paramedian skull base area in the infratemporal area. These lesions include the foramen magnum based extraaxial lesions like meningioma, some schwannomas arising from the posterior fossa, cerebellotonsillar intraparenchymal lesions arising from the vermis and the fourth ventricle, and some of the exophytic brainstem lesions coming into the fourth ventricle, and some aneurysms arising from the vertebro-basilar complex at the pica aneurysm. These are some of the lesions which are come across through the posterior midline approach. And this is the standard venous anatomy and the craniotomy what we routinely do to approach these lesions. And to enter into the interdural compartment, the normal notion is to use the VR Y-shaped incisions. But this can lead to some of the complications, like when you cut the occipital sinus, it can lead to copious bleeding. And coagulation of that bleeder can lead to the shrinkage of the dural edges and difficulty in primary or watertight closure once there is a shrinkage, or you need to sandwich with some kind of duroplasty. There could be some potential venous complications, especially in few cases of venous anomalies, drainage sinuses when they have a anomalous association here. And these kind of unable to close the primary dural closures can lead to CSF leaks. Some of the literature is showing up to 13%. And this can lead to pseudomeningocele, and leaks can cause the meningitis, and all those complications can be avoided with the occipital sinus sparing approaches. Most of these problems can be seen in pediatric cases more than the adult cases. So to avoid this, the approach will be like a suboccipital sinus sparing approach. This includes like where instead of the conventional dural opening, we can make a small paramedian elliptical incisions either on the one side or two sides, depending upon the severity of the lesion, or it is at the like main venous sinus confluence with the occipital sinus junction. You can use some kind of T-shaped incisions to enter into the cranial cavity. So what about the occipital sinus is like, this is the smallest sinuses, lies in the midline attached in the falx cerebelli, communicates cranially with the confluence of the sinuses, caudally with the vertebral venous plexus, the marginal sinus at the foramen magnum. And since it communicates with the posterior internal vertebral plexus, the occipital sinus receives a small amount of blood from the spine and the spinal cord. The occipital sinus connects with the extracranial with the intracranial venous system, hence can be considered as an emissary vein, as the literature supports that. The most prominent function of the occipital sinus is to provide an alternative route to the venous drainage of the vertebral column when the venous return through the IJV is compromised in case of some like thoracic outlet syndromes kind of thing. In case of absence of the transverse sinus, occipital sinus becomes the main pathway of the venous drainage of the brain. That's called the oblique occipital sinus, this is called. And these are some of the variations reported with the occipital sinus variations. So this approach, this been reported in one of the recent journal in World Neurosurgery in the April issue. Other than this one report, there are no reported incidences for this approach, but many people might be doing on a routine practice even though it is not reported. So my approach is like make a tailored suboccipital craniotomy using a small single burr hole at the confluence and making a tailored craniotomy suiting to the size of the lesion. So it may be anywhere on the occipital sinus confluence to the foramen magnum level, enian to foramen magnum level, depending upon the location of the sinus. You can able to titrate your craniotomy placement. Sometimes you can use the navigation to do the craniotomy there. Once you do the craniotomy, do a sizable paramedian durotomy depending upon the size of the lesion. If it is perpendicularly in the midline, you can go the bilaterally. If it is more towards the one side, you can use the single side elliptical dural durotomy. And after addressing the pathology, you can try to achieve the primary dural closure, preferably a watertight dural closure, which can prevent the further CSF leaks. So this is an illustrated case, 3-year-old kid presented with a small pontine cavernoma projecting into the floor of the fourth ventricle. So this is the complete sequence showing the cavernoma with a bleed. Actually, it was subsided after the bleed. We operated this case once the bleed was subsided. So this we approached through the right paramedian durotomy, So as the lesion was arising from the left side, you can take the tangential path to reach through the one-sided opening of the dura, which I can show. This is after the craniotomy. You can see this is the cranial end, this is the caudal end, this is the midline falx cerebellar and the dura on either side. This is the place for the occipital sinus, and this is the confluence of the sinus. We didn't go complete end of the confluence, so this craniotomy was made somewhere in between the inion to the foramen magnum. So the video is, once you expose this one, you keep a small gel foam to avoid other side of the dura, which we are not using. So we make a small durotomy and make it an elliptical so that you will get a better exposure of the operative area, and you can able to retract the dura onto the opposite side. Once you made the durotomy, you open the cerebello-tonsillar cisterns here, and you can make it as a kind of telovelotonsillar approach and reach to the fourth ventricle, and you can see the stained floor of the fourth ventricle. That is because of the old bleed from the cavernoma. The rest of the approach is stained. This tumor was removed under the navigation and the nerve integrity monitoring area. So complete tumor was removed. After the hemostasis, you try to achieve the primary dural closure without any hassles. So you can see the proper dural closure can be achieved with this. So because here handling of the dura, handling of the rest of the cerebellar structures or the brain's parenchyma is very minimal, so the complications in the bleeding will be very less, and you can successfully close the dura without having any problems. And after completion, so this is the post-op scan showing the complete removal of the tumor, and the kid immediately after the post-op, after the recovery room, patient is totally intact compared to the previous preoperative surgery. So this is another case where you can see a large sizable quadrigeminal arachnoid cyst. He was initially managed conservatively. He developed some kind of visual symptoms. He is having a repeated episodes of headache, so we wanted to operate this case. So you can see the size of the craniotomy, what we did for this case, and this was operated through the same, like we use a T-shaped incision at the confluence of the venous sinuses and the junction of the occipital sinus to enter and to reach this area. This was managed with the endoscopic approach actually. Instead of microscope, we used endoscope because it's a small size incision. The 2 centimeters craniotomy was used to reach to this area. This is basically infratentorial supracerebellar approach, tailored craniotomy and tailored dural opening. So here we did a cystocysternostomy kind of approach, and we try to decompress the cyst as much as possible. And this is a simple straightforward surgery without having any complications. So this is another case actually. This is a large sizable posterior third ventricular craniopharyngioma. Patient initially presented to us with features of raised ICP and a gross hydrocephalus. Initially I did this endoscopic third ventriculostomy, and cystocysternostomy was did using the flexible scope in the first instant. He was reasonably okay for almost a year, and then he came back with the cyst recurrence. This is before the second surgery. The cyst was mainly situated in the posterior third ventricular area with a sizable calcifications all around the cyst actually. So this was also approached to the same T-shaped incision at the level of the transverse sinus and the occipital sinus junction. These are the dural openings, and this is the surgical video. After doing the durotomy, you can use the microscope to do the initial dissection. So we are opening the arachnoid and the posterior third ventricular area, and after reaching the cyst, you can decompress the cyst and remove the calcified portion. Once the cyst was decompressed, the cyst capsule was gradually mobilized from the surrounding structures. So you can see the cyst was completely separated out, and at the end of the cyst removal, you can see the complete posterior third ventricular area. We use an endoscope to look around, is any residual component of the cyst is there or not. So after complete successful surgery, you can able to close the dura properly, the primary closure, and you can see there is no residual tumor on the post-operative scan. This is the immediate CT is due for the contrast MRI in a month or 2. This is another case of, this is the actually post-op scan with craniotomy defect and the skin incision you can see. This is another case of midline posterior fossa tumor. This is a hemangioblastoma operated around 3 years back. So we use here bilateral dural opening because one side it was not able to reach completely. So we use an endoscope, microscope combination coming both the sides, preserving the occipital sinus. So this is the craniotomy, and you can see the bone exposure. and this is a post-op scan showing the complete excision of the tumor. He's asymptomatic for the last 3 years. So in nutshell, this is a simple procedure where occipital sinus sparing approach to the midline or para-median posterior fossa lesions can be performed without compromising the exposure or without any added deficits. It allows preservation of occipital sinus, primary dural closure, thus reduces the CSF leak and pseudomeningocele formation. In some cases, because of the venous anomalies, oblique occipital sinus is not rare. Usually, whenever you're operating these cases, it's always better to have a venogram properly studied before we venture into the managing these lesions. Thank you very much for your patience hearing.
A nice presentation,
Thank you,
Ramesh. Please.
Yeah, ideally it could have been cystocystinostomy and the other side also, because there was dense adhesions and it is stuck to the brainstem and there are some venous plexus all around. So we couldn't do the other perforation. So we are managing this case without any further surgeries. As of now, is withstanding. No, we take the bow hole on the midline. We extend the craniotomy to the opposite side also. One side where you are approaching will be the larger component. Other side also, small component of the craniotomy will be crossing the midline. That will allow you to retract the dura a little bit with the sutures. If your craniotomy is to the bang on the midline or to this side, so reaching to the midline will be difficult. So it will be leveraged to the opposite side. So depending upon the size, suppose if you are planning to open the dura on either side, we make the craniotomy standard suboccipital craniotomy, sizable. It's not the wide craniotomy what we conventionally do. So depending upon the size, we can titrate your craniotomy size.
We don't need to remove the posterior arch of the C1?
No.
Never?
No, it's not never actually. It is where your location is situated. Suppose if it is a foramen magnum lesion or a cervicomedullary tumor, so you have to remove the tumor. But there, the dural opening is again, we don't want to compromise the occipital sinus. The whole concept is try not to coagulate the dural margins, try not to compromise the venous circulation. That is the main goal of this talk.
What I normally do at my center right now is mostly pediatric posterior fossa tumors on the midline. So is it possible for me to, try this technique?
Definitely. We operate a lot of medulloblastomas.
I'll be standing on the side of the patients?
From the back side. You can tilt the head little bit so that your direct access will be to the patient.
Okay.
So not in the direct prone position, you can tilt the head, angle it to the opposite side so that your posterior fossa approach will be straight from the back of the shoulder.
Back of the shoulder?
Yeah, from this side.
Thank you very much, Professor.
Thank you. Dwarka.
Any other comments? Thank you,
Sir,
Ramesh.
thank you, sir.
Very nice one.
Thank you, sir.
In fact, that actually the time we spend to do the mobilization is much more,
Yes, sir.
but this looks much easier.
Yeah, initially when we start, it looks difficult, but as we practice, it's as simple as doing any conventional procedure.
Right.
Because you take a lot of time in controlling the bleeding and putting cartons here and there. Ultimately, you're compromising your operative area also. And more like brain exposure, more will be damaged. Dryness can lead to dural damage also.
Thank you very much. It's very nice paper, and I think we call Dwarakanath, Dr. Dwarakanath, to speak on the approach selection for petroclival meningiomas.
Our next speaker is Dr. Draknath Srinivas, MS, MCH in Neurosurgery, IFANS, who has a fellowship in functional neurosurgery. He is currently working as professor and head of neurosurgery in NIMHANS. So I invite him to take lecture on the topic, Approach Selection for Petroclival Meningiomas.
Zoom के थ्रू करना है तो इसका इंटरनेट कैसे होगा वाईफाई कनेक्ट करें हाँ न्यू ये 235 685
685
3261. 1 2 3 4 5 6. ऑडियो लगेगा आपको? स्टॉप वीडियो? हाँ स्टॉप वीडियो. ज्वाइन
Recording in progress.
ऑडियो म्यूट करें. आपका स्पीकर भी म्यूट कर सकते हैं यहाँ का. जी शेयर स्क्रीन डायरेक्टली शेयर बोले पीपीटी. ठीक है. ये मिनिमाइज करना पीछे. ये ठीक. ये ठीक. लास्ट ऑप्शन शेयर. स्क्रीन एंटर रखे सिर्फ शेयर बोले. ये जो विंडो है इसको मिनिमाइज करो. Okay, so the petroclival meningiomas have been called the king cobras of neurosurgery, and that is precisely the reason why they're the most difficult tumors in the human brain to remove completely. The complications are huge, so I'll just go through what are the possibilities and how we manage these tumors. And they have been basically divided. They're not a homogeneous entity. They have been divided into petroclival, sphenopetroclival, clival, foramen magnum, petrosal meningiomas. And the entire definition of the petroclival meningioma depends upon how the fifth nerve is displaced by the tumor. So it could be either caudally or laterally or the anteriorly. So that divides it basically into the anterior petrous type, the petroclival type, and the tentorial type. The retrosigmoid has and is the workhorse. It's very simple, it's fast, it's effective. You avoid venous retractions due to temporal lobe retraction. But the only main problem is if the tumor is hard, you need to, because the corridor is very narrow, you have a high risk of postoperative 7th and 8th nerve paresis, and the 7th nerve actually goes up to almost 15 to 20%. And of course the risk of cerebellar retraction, damage to the Dandy's nerve and subsequent venous infarction, Dandy's vein, sorry. Now, the transpetrosal, of course, the main disadvantage is it's a very time consuming process and you could develop a CSF fistula, but what it does is it reduces the working distance, provides early devascularization and multiple corridors. So the transpetrous have been traditionally divided into the anterior transpetrous, of course, through the Kawase's triangle, and the posterior transpetrosal approach, which was popularized by Shaker et al. And the main difference is that it depends on these zones. So if you see, this is the transition between zone 2 and zone 3, which are separated by the internal acoustic meatus. So any tumor which actually goes down below the internal acoustic meatus is difficult to approach from above, because that's an anatomical limitation of your anterior petrosectomy, that you cannot go below the internal acoustic. You can pull it, but the problem is we will not be able to do it properly. And the third is the total petrosectomy, in which is a large tumor going from top to bottom, hearing gone, 7th nerve gone. Then a total petrosectomy is good because it gives a very good exposure. So like I said, what I do is either do the retromastoid, I mean we do all the three approaches, and basically the approaches are based on the zones, and I'll just go through them quickly as to what approaches I follow. So this is predominantly a zone 3. These are basically either anterior petrous or petroclival, and basically in the zone 2 and zone 3, and you don't need to go very much above the 10th. So here a simple retromastoid craniotomy and tumor excision is good. Like I mentioned, the only things you have to keep in mind is the dominance of the the dominance of the venous sinuses. And this is a quick repack of a standard retromastoid excision of the fifth of the petroclival meningioma here. And you can see the fifth nerve there, which is displaced posteriorly. So this makes it a petroclival, posteriorly and superiorly. And then you get this narrow corridor to work. And this is probably the biggest problem, like I mentioned, that in a hard tumor, you need to actually do a lot of dissection between this narrow corridor, and the risk of seventh nerve is more. So this is dissecting of the fifth nerve, and then the tumor is removed. So this retromastoid has remained the workhorse of neurosurgeons, and because of the familiarity will continue to remain so. So like what So like what Dr. Goel mentioned in his talk is that sometimes you don't have to actually do the pure retromastoid, you can combine it with the lateral supracerebellar approach, in which the tumor is also attached to the inferior surface of the tent. So then instead of retracting the cerebellum just medially, you retract it medially and inferiorly, and then you get a very good plane. If you can see the images over here, you can see the attachment to the tent. So this you'll also have to work above where the fifth nerve is. So it's basically a lateral supracerebellar approach which gives you good results. So, but what happens if the tumor is predominantly in zone 1, that is the uppermost zone? These tumors can be removed through the lateral supracerebellar approach, but there can also be approach from the subtemporal region. For example, this patient. And the other thing which I forgot to mention is the importance of having a look at the T2 images because this edema over here actually precludes you from total excision, because there is definitely a penetration of the pia arachnoid by the tumor, and you have to be careful, otherwise there are going to be brainstem signs post-operatively. So we electively left behind some of the tumor for which we gave gamma knife. But again, if you see this tumor, if the tumor is soft, it is good plane, then you can remove the tumor in toto, like this tumor, or this tumor, which basically are petroclivo-tentorial tumors, in which you can get a good excision post-operatively, leaving probably a little bit of the part in the cavernous sinus here. Coming to the posterior transpetrosal approaches, the posterior transpetrosal approaches have been divided into retrolabyrinthine, translabyrinthine, and the transcochlear, depending upon whether the hearing is preserved or not. And mostly you will see in petroclival the hearing is usually preserved, so a retrolab petrosectomy is usually done. Yeah. There's a lag here. Okay. So for example, these tumors which involve both zone 1, 2 and 3, you will see that there are limitations of either the retromastoid or the anterior petrosectomy, because both are inadequate for some parts of the tumor. So then you need to have the best of both worlds, and then probably we do a retrolabyrinthine pre-sigmoid subtemporal transtentorial approaches, which actually combines the best of the two worlds. So here you do a standard suboccipital craniotomy, then you do a temporo-occipital craniotomy, and then you start skeletonizing the sigmoid sinus and the superior petrosal sinus. So this is the this is basically a retrolabyrinthine bone work, in which we preserve the labyrinthine as well as the semicircular canals, so that hearing is preserved. The entire idea of this approach is to expose the Trotman's triangle and the pre-sigmoid space. So once you expose the pre-sigmoid space, you can enter in the pre-sigmoid area and then reach on top of the tumor, which I'll be showing now. So you have to be careful about the two structures which you have to be careful. One is the semicircular canals, and the second is the seventh nerve. So the seventh nerve, we devised in that if you use very high voltages on your electrophysiology, you can actually stimulate the seventh nerve and identified. Here we are using electrophysiology to identify the probable course of the seventh nerve. And once we have done that, we mark the seventh nerve, and then the rest of the petrous bone is drilled. So this is, and finally you get this Trotman's triangle, which is the pre-sigmoid area, which is basically a region of interest, and this is going to be a superior petrosal sinus. So once you have once you have seen the superior petrosal sinus, the next step is to do a temporal dural opening as well as a pre-sigmoid dural opening, and then open it and ligate the superior petrosal sinus. So here we are ligating the superior petrosal sinus, and once you ligate the superior petrosal sinus, what you have to do is you have to cut the tent. So this is what we are doing over here. Why is it jumping like this? So if you see over here, we are cutting the tent, and once you cut the tent, you have to go, you have to cut the tent completely. And I'm sorry, there is. I'll just restart this video. No, the video is just jumping. I don't know why. Anyhow, it's okay, leave it. So then the steps of the meningioma as devascularization, then decompression using the CUSA, and then dissection away from the cranial nerves. Here you can see we are isolating from the fifth nerve and the Dandy's vein, and below that you will see the seventh and the eighth nerve complex. Then as you start decompressing the tumor, what you will see is the basilar system, the vertebrobasilar system, along with the ICA and the ICA perforators, as well as the where the two vertebrals join to form the basilar. And then when you start dissecting medially, you can identify the fourth nerve. The fourth nerve is dissected and separated. And then the final part is, the most important part is to dissect it off the brainstem. And this particularly depends upon the T2 images as to the decision as to you will take whether to remove it in toto or remove a thin layer along the brainstem. So once you have done that, this is the Dandy's vein here, that is the fifth complex, and below the fifth complex will be the seventh and the eighth complex. And this is the basilar system completely visualized. You can see the basilar perforators, you can see the ICA over there, this is the ICA here, this is the ICA here, and this follow up you can go up to the third nerve. So this is the extent of tumor resection of the, which it gives you a very good exposure of the entire petroclival complex. These are the post-imaging, operative imaging of the posterior petrosal approaches. And the advantages, you can treat very large tumors like these. If you can see both the supra and the infratemporal component, and this is the post-op, leaving behind a bit in the cavernous sinus. Similarly, a very large tumor here, this is the patient post-op. Similarly, large tumors like this can be removed through the posterior petrosal approaches. When do we do the combined approaches? The combined approaches combines both a supratentorial approach as well as the posterior petrosal approaches. So we do it in stages. For example, this is a very scary tumor. So first time we did, we went the retrolab pre-sigmoid approach and removed the posterior fossa component. And after 3 to 4 months, we came back and did the anterolateral transcavernous with an anterior petrosectomy and removed the rest of the tumor, again leaving a bit of the tumor in the cavernous sinus and the one which was stuck to the basilar artery. This again depends upon the consistency of the tumor. This tumor is very fibrous, so we had to leave a little behind. And this is 2 years after post SRS. You can see the patient has very good tumor control. So what are the predictors of extent of resection? One is tumor margin, brainstem pile invasion, infiltration or encasement of the neurovascular structures, and firm tumor consistency. These are the most important things. And the second is the history of radiotherapy. If radiotherapy is given, again your entire excision becomes difficult. So how do we compare it? Like I mentioned, the retrosig has a higher incidence of 7th nerve, while the anterior petrosal has a higher incidence of 4th and 6th, while this posterior petrosal again has a slightly increased incidence of 7th. So limitations, like I mentioned, what are the limitations of posterior approach is that there is a risk of injury to the sigmoid sinus. So you have to be careful that the patient does not have a unilateral dominant sigmoid sinus when you're operating on that side. There is a risk of injury of vein of Labbé. A high jugular bulb is probably a relative contraindication because your exposure becomes limited. And tumors that extend into the anterior end of the petroclival groove, which is hidden on the opposite side, you might not be able to access it because you're coming from slightly above, from behind. Anterior approaches, again, the limitation is your internal acoustic meatus because you'll not be able to visualize it. Again, it is a much narrower corridor than the posterior petrosal approach, and risk of injury to the vein of Labbé is still there, though now we can use a preoperative lumbar brain placement to relax the brain and do the surgery. So what are the good, you can get a very good exposure, 4th cranial nerve, you can see the Dandy's vein, the 5th nerve, the 6th, the 7th, 8th complex, you get a good bone work, and you can see the basilar. So these are all the advantages of the posterior petrosal approaches. But of course, indications of venous infarct, this again, you have to be very careful, and we have burnt our fingers many times as to if you ignore the radiological imaging and take a decision to excise the tumor, you will end up in disaster if there is pile breach. Firm tumors are very dangerous because once the vessels is encased, there's a high risk of vascular injury like what happened in this case. We had to not only leave behind the tumor, but the patient also had an infarct. Sometimes it's very, very hard and calcified tumors. You do a planned subtotal resection. We left this part attached to the brainstem, and this is the patient post gamma knife. So the approach is generally decided by extent, either a simple retrosigmoid when it's in zone 2 and zone 3. A zone 1 would be anterior petrosal approaches, while zone 1, 2 and 3 would be a posterior petrosal approaches, and anything bigger than that probably needs a staged combined approach. So I will stop here, and we need to tailor approaches as to how we approach these difficult tumors. Thank you.
Yes, thank you, Dwarkanath. It's really a tough job, and as you said, king cobra, not cobra. It's a king cobra for the neurosurgeons. It's always very difficult to decide which way, and I think only by experience one can able to master it. Certainly not in the beginning of the career. I just wanted to know about one thing about this extensive dural based. That is the tent is the very extensive one. They are more difficult. I've seen some of the meningiomas which is infiltrating.
Yes.
From the petroclival, goes to this sinus, cavernous sinus region, and then comes down. And they find it's very difficult to combine both approaches,
Yes.
and still not able to excise completely.
Yes. I agree with you, sir. The on-plaque types what you're describing are very difficult. What makes it more difficult is the consistency of the tumor. If it's firm fibrous, it's a nightmare. Relatively cusable tumor, you can still take it out and do a good job. Regarding the cavernous sinus, sir, you can do a transcavernous approach. We've done it, but you see, if the patient does not have a 3rd, 4th and all pre-op, cavernous sinus generally there's a risk of cranial nerve paresis. So now with the outcomes of gamma knife being so good, I'm not sure whether there's any rationale in chasing these tumors. Sometimes the tumor itself is soft, it makes its own path, you can take it out. That is fine. But opening the cavernous sinus and trying to remove a bit of the tumor after you remove 95%, I don't think it is necessary. And similarly, the bile invasion is a very important predictor of not only the grade of the tumor, but also the difficulty in removing the tumor. And generally, it's not the arterial which is important here. What happens is there is a venous injury, and this venous injury can lead to severe venous infarcts. So these patients become disabled post-op. So these two things, I think we have become a little more conservative now, and anything in the cavernous sinus, as well as if there is preoperative edema, generally leave a bit behind and give gamma knife after 6 months, 3 to 6 months.
Yeah, I too agree, because when you see the earlier days presentation by Laligam Shegar, Takanori, Fukushima, and the way they expose it, initially itself they expose very large, so that they make the surgical technique much easier for them.
Yes.
But then then you need a lot of time spent on that.
Yes, sir. I agree with you.
That's one point
Yes.
which was.
Yes, sir. And actually now what we started doing, which of course we discovered by chance, we started staging the approaches. So what happened was, sometime we ran out of ventilators because some patient had deteriorated and all. So we stopped the bone work. And then we realized that actually bone work takes a lot of time, especially in a posterior petrosal approach as well as petrosectomies. The bone work itself takes 3-4 hours. So now what we do is, we generally do the bone work on one day, do an extensive dissection, and then come back after 3-4 days and do the tumor removal. Then both the surgeon is fresh, and generally the surgeon is more comfortable rather than trying to remove the tumor at 8 p.m. in the night when everybody is tired. Doesn't make sense. So we are planning to publish our paper on this stage petrosal approaches.
Yeah, because the way I bring this to the discussion point here is, I've listened to Professor Laligam Shegar's those days presentation. They used to do the same patient on 2 days. Patient is still under anesthesia. The bone work is done by a group of specialists, right? And then the neurosurgeon entering. So probably the ENT surgeons were there. So, but then techniques became better and better. Now we are able to master. So, how was your other comments? We know this also there. You can make a comment, please.
Thank you, sir. Actually, for these giant petroclival tumors, as you have mentioned, the fibrotic varieties with vessel encasement, you want to stage the tumor resection. So, which staging you find better? Going for anterior petrosal approach on one day and posterior petrosal approach on another day, this staging, or bone work on one day and then tumor removal on another day, this staging?
No. See, the bone work we do on one day. Okay. See, the tumor in which we have to do both anterior plus posterior petrosal are very unusual. I mean, among our experience, we've had only 5 cases in which we've had anterior petrosectomy as well as a posterior petrosectomy. Both are completely different. So if we are selecting the anterior approaches, because we do transcavernous as well as drill the Cavaz's triangle, so we do the bone work on one day, do not open the dura, and then come back after 3-4 days and then do the tumor work. So for us it's bone work followed by tumor work. It is anterior petrosal and posterior petrosal. If you are doing, we stage it by months actually. We do the posterior petrosal. After 3-4 months we come back and do the anterior petrosal, anterior approaches.
Thank you.
Any other questions?
I really enjoyed your videos and talks, sir. My one query is, do you try to predict the consistency of the tumor preoperatively, evaluating the MRI scans, and how positively have you predicted it?
We try predicting by the T2 images. We're around 70-80% successful. Sometimes we thought the tumor is very hard and gone, and it turned out to be soft. It happens in pseudomatous meningiomas, where it's highly calcified. The CT appears scary, but actually the tumors are very soft. They come out very easily. More than heart tumors, I think the most difficult are the ones with bile invasion. Those are the ones, especially if we try to dissect on the brainstem. Those actually end up with deficits.
What we do is that along with MRI, we also do the complete CT, minimal cut CT. the calcification and fibrous is more well appreciated if you combine the CT and MR, because totally depending on MR sometimes very deceptive.
We do now. All our patients get a CT because for the bone work we need the imaging. So all patients get CT and MR. It's a combined thing. We do it. I mean, we also use the same CT plus MR combination.
Hyperdensity. If it is more hyperdense, it tends to be more fibrous. But regarding judging the, the density of the tumor, along with T2, we can use ADC as well. So there are ADC.
Yeah.
There are some studies which suggest that more than 80 ADC values, they tend to be
Absolutely
much higher.
Absolutely, I agree with that.
Any other questions? Okay, can we close the session? It's very nice presentation.
Okay. Thank you, sir. Is Dr. Sambhat Chandra sir here? Okay. So thank you speakers for your enlightening presentation and valuable insight. As a token of our appreciation, we would like to present you with a memento and a certification of appreciation. I would like to invite our esteemed chairperson, Dr. JKBC Parthiban sir and Dr. Devabhadra Sahana sir to give out the mementos and certificate. Dr. Ramesh Tigla sir, please come forward.
Dr. Dwarknath Srinivas, please come forward.
Dear attendees, we have now reached our lunch break. However, we would like to remind you that we have two concurrent sessions happening right now in Hall B and Hall C. If you are interested in attending these sessions, please feel free to head over to the respective halls. And lunches are also being served. Thank you. The session is now concluded in Hall A.
आपल्याला तिकडे जायचं नाही पण सगळे ओके सगळे कुपन घेऊन ठेवतात 2 4 तुम्ही आम्ही आले चौघ साऊंड शेडिंग आम्ही तिकडे निघतो तिकडे काय घ्यायचं तुला आता फक्त अपडाऊन क्रॉस एक मोठी पॅच कॉड घ्यायची नाही तुम्ही जाऊ आता ते कुपन घ्यायला की जातात कुपन तुम्हाला देतील तुम्ही जाऊन घेऊन या आम्ही बघतो
कॅमेऱ्याचं इथे कसं काय कोण थांबणार काय
कोण इथं ठेवतो नाही
असू दे की तुमच्याकडे
होतं ना परत ऐकायचं
हा. एक एसडी घेतली एक पॅच कॉर्ड घेतली
HDMI त्यांच्या डिव्हाइस पासून
मोठी घेतली की कॅमेऱ्याला ना
कॅमेराला मोठी आली ह्याला पण सांगू शकत नाही न्यूरोलॉजिकलचं डिव्हाइस आहे अरे ते न्यूरोलॉजिकल डिव्हाइस आहे ना
मग 2 घेऊ का HDMI
HDMI to HDMI घ्यायला लागणार
एसडी लागणारच नाही का
याला कुठे आहे मिनी प्रोला कुठे आहे
हा कधी आत्ता बंद केलं त्यांनी
पॉवर सप्लाय आहे पण तेवढा बॅकअप आहे
आता तुमचं टार्गेट ठेवा
कुठल्या डिस्क कधी
बॅकअप वाली
म्हणजे
ठीक आहे त्याच्यात कॉपी करा
त्यात लावलं की
त्यात लावलंय बॅकअप